Time is 8:33 a.m. and the Oregon Board of Physical Therapy is entering into public session.
Madam Chair. For roll call, Timothy Brinker,
Here.
Aaron Crawford,
Here.
Mariah Frank,
Here.
Sandra Hahn,
Here.
Koku Okamura,
Here.
Susan Reynolds,
Here.
Erica Shanahan,
Here.
Dwight Terry.
Here.
For staff, Michelle present, Sherry,
Here.
Gayla,
Here.
Sarah, and AAG Joanna.
Here.
And I do believe we have members of the public joining remotely.
The Oregon Board of Physical Therapy Board meeting has a statutory purpose to protect public health, safety, welfare for all Oregonians by maintaining standards for quality care, professional skill, and competence through the effective regulation of the practice of physical therapy.
This is just difficult to see, but a copy of the agenda. The agenda is posted on the board's website, and all members have this at their stations. One note is that we do have an item scheduled for 9 a.m. exactly. So the board anticipates, going through items somewhat out of order, but we'll return to that item at 9 o'clock when the presenters are here. That, Madam Chair, it brings us to the consent agenda. Materials were set out ahead of time to board members for review and include typically the minutes, the ratification report of licenses issued, and the director's report and financials. I guess the first point of order is if anyone had any questions or corrections on the September minutes. None. And if there were any questions on the ratification report of licenses issued? None. Sarah, if you could move to page 10 of the packet, please. Back one. Yep. One more. There we go. And are you able to zoom in? I do want to note a couple of things because we are in a new biennium and the way we track the 2 fiscal years, the second column is intentionally blank. We hold it there just so that you can see over the course of the biennium what's populated. So the first line is the budget to actuals run rate for the current fiscal year. And of course, the third column, just at the bottom of that page, is the biennium total, which of course is the same. It's the fiscal year for right now. Scroll down, please, Sarah. Hold there. There's a list of the other attachments. When I get to the end of the executive director's report, I will ask members if you had any questions on the report or any of the attached financial documents that just go into the month by month and biennium detail. And because we weren't able to bring it to the September meeting, we do also have the final biennium report and fiscal year report. Those are also posted directly on the website for anyone who attending remotely or after the fact. Licenses holding pretty steady. You can see on the next page where we are with the same sort of expected slow growth. And the current growth rate that we're seeing for this biennium is at about 1.5%. The same time period for last biennium, the rate was pretty equivalent, 1.36%. you can see where we ended up last biennium was just about 0.25%. But we do typically, it's fall, right? There's a lot of graduations, so we typically do see a higher rate in the beginning of the each fiscal year. And if you scroll down a little bit, when you map that into, when we try to look at total available workforce, and I try to highlight this each time because when we look at our license count, it is important to keep in mind that not everybody who holds a license to practice in Oregon is practicing in Oregon or even living in Oregon. So what we know is what the total available workforce is. The Oregon Workforce Survey administered by the Oregon Health Authority that we talk about later, that is a mechanism for us to find out more about who is actively practicing, who's planning to practice. And what we've added to this is the compact privileges that are purchased to practice in Oregon. And you get this idea of the total authorized to practice in Oregon. And we are, PTAs have continued to grow in the purchase of compact privileges. They're now at approximately 10%, where 6 months ago they were 8%, 7-8%. So we're seeing growth there. Those are active privileges that at this time, but that doesn't mean that the individual, they may have finished their rotation into the state. The other trend that we're seeing is that individuals who are working telehealth for different companies, they may acquire compact privileges in all states that they might have a patient in, but they may not have ever practiced yet and may never will. But they have that, that's the potential of individuals authorized to practice. Next page is on exam and endorsement applications. I did leave in the numbers from last biennium so that you had some comparison relative to, so the top chart, you'll see and down one. So that's the total, cumulative total. But here you'll see for this biennium, and we do report and these in time periods in between board meetings, consistently biennium to biennium. And if you scroll to the next table, you can see relative to, we had a much higher beginning. We're a little bit pretty much on par for the end of October between last biennium and this biennium. But this is a way so that you can see over time, are we trending to what we've done historically, or are we trending up or low in number of applications? And the same is true for the endorsement applications on the other page, which do appear to be down a little bit from the same period last year. So that's one of the trends that we'll be monitoring. The next series of pages begins to focus on the purchase of compact privileges. And the first table with the, Sarah, if you go forward, page 14. So the first page is where are the individuals that are purchasing those compact privileges into Oregon? So the numbers on the map in the table quantify what we would expect. Washington State is a primary purchaser into Oregon. Texas, we know that a lot of travelers come from Texas. They have a large volume population. And of course, California is not in the compact. The gray states here are non-participating yet. So Washington is really our only direct border state for input into it. The tables go through and just highlight the numbers for PT, PTA, so you can see some information on trends. And then I do, Sarah, if you would skip to the bottom of page 15 and the map. This is a different viewpoint of, these are Oregon licensees that have used their Oregon license to purchase a compact privilege elsewhere. They may, as I mentioned, still live in Oregon, but telework, or you can see Washington, 279, right? Not surprising with the Portland metro area, more folks may live here, but work across the border. It was 100 coming the other way. And one other note on this is that if you, bottom of the table on page 16, that represents 572 privileges. They're, in this case, it would be the individuals. On the other chart, purchasing in, or people, I'm sorry, let me start over. On this chart, you may have one Oregon licensee that has 5 privileges in 5 different states. Okay, so the 572 is the number of privileges that have been purchased, but the number of individual people is closer to about 315 making use of this benefit. The next page I won't go into in detail, but this is, and at some point we're going to have to drop this chart because it gets smaller and smaller, or I'll need to summarize it. But this is since the inception of Oregon's participation in the PT Compact and then the spread of both PT, PTA purchases in the different jurisdictions that are member states in the Compact. And then you can also see the CPs issued, which is the center table. And one of the things that you see there that is important for a conversation we'll have a little later in the agenda is if you look at of the 2,100 purchases that have been privileged since mid 2018, only 570 of those are renewals, right? So about 2/3 of folks don't renew. And there's some changes. Somebody might let a compact privilege expire and then they'll purchase another one months or years later. And that counts as a new initial under the language of the compact. So it's not an absolute people never renew. But roughly this is what we're looking at, that 2/3 of the population roughly will buy a privilege, but then not renew. If you compare that to our drop off in renewals, we historically have seen between a 14 and a 17% non-renewal after the renewal period. Some of that creeps back up because we do see late renewals, even up to a year later. But I wanted to highlight those particular numbers. The page, top of page 18, please. This is the open case and aging report that shows you at just an aggregate level how many open cases are before the board. What's in post, that means after a board meeting, there may be the hearing process or other things. That's what post means. And then the number of remaining cases and then the aging on that. And the note here is just part of your approval of the executive director's report is authorizing the extension of the investigations pursuant to the statute listed. Then the bottom of that page, again, looking at another view into compact, you can see that what this breaks out is the total number of cases, and then compact is the subset of that total number. Are compact cases. And then what we give you is the count at the end of the biennium, or in the case of 25-27, it's current as of when the report was written, what those populations are. And that's how we're building the percentage of complaints as a percentage of the total population of Oregon licensees versus compact privilege holders. You can see that so far we're trending at 26% of the complaints that we have so far this biennium are compact related. And you can see that the compact license count as a percentage of population at 0.77 as opposed to the licensee population, which is 0.2. So it's a higher rate of that population we're seeing complaints. Now that has nothing to do with the complexity of the complaint or the content. This is just the raw numbers of complaints, and it shouldn't be conflated with discipline for either population. This is just complaints. Next page, bottom of, there's some highlights on outreach. Uh, and then on the administrative side, on this dashboard, I do want to highlight that the under employee satisfaction, every agency is required to uh, have a survey of their employees once a year at the same time of year. And I'm pleased to report that our agency score is a 5 out of 5 on the Gallup Q12 survey that the state of Oregon uses. Last year, we were at a 4.92. And we do currently have the highest employee satisfaction in the state. So just want to thank my coworkers and of course the board. This is a great place to work. The other updates, the one yellow that you have on succession planning, I tend to report very conservatively. This is due in the end of December. I have not done it yet. And so it's just a caution light to make sure that you're aware that it's due soon. I do not anticipate any concerns in completing it. I think just one other highlight at the bottom of that page that's worth highlighting is that, and we'll talk about it later when we talk on strategic planning and things, but there's been a significant amount of effort required around information technology systems. And some of that is just the state of the world today in compliance. So there's a lot of activity and mostly Sarah is being involved in that. We also, you might notice we had been reporting on our planned migration to the newest version of our software product for licensing that we've frankly been trying to do since 2020. The vendor is not in a position right now to have done that. And so we have pulled the migration off because of course we're about to head into renewal season and need to keep it as stable as possible. The state of Oregon in general, in part because many other agencies have already reached the end of their contract with this current vendor. And so we've also been participating in a statewide effort to release an RFP for a statewide contract for different licensing systems. Our current vendor may or may not bid for that. I'm not sure. But that body of work is also happening. There is some risk given where things are with the vendor. We do have a COOP plan or a continuity of operations plan should anything become critical. But that's another reason why we're keeping the build that we have right now stable, even though there's some additional functionality that you've identified and that we've wanted to implement. We're just not able to do that at this time. I'll pause there if there's any questions on any of the other sections of the report or what I've covered or any of the attached financials. A lot this time. If not, Madam Chair, then you would need a motion for the consent agenda.
I'm curious about the general administration that's currently working with the outside auditor. Tell me more about the auditor's role and what they're auditing, please.
Absolutely. As a semi-independent agency by statute, we are required to have an external financial review done for each biennium. The results of that, you will see those results. It's also part of our mandatory reporting to the governor's office and to the legislature. They'll highlight those reports. We are contracted with what is now Baker Tilly, used to be Moss Adams accounting firm. And it's the same firm that the board has used the last, I believe, 2 biennia. But they come in and they go through and do acceptable use practices. They look at all of our policies and procedures, do some sampling, review our financial controls, and then they will write a report that they submit with recommendations.
Thanks. Are they completing a financial audit or a financial review?
It would be at the level of review.
Okay,
So
so
they will compare to our internal controls, and they will, if they have any findings, but it's not a detailed, more forensic financial.
perfect.
Yeah.
That sounds appropriate for the board. Thank you.
Sandra, I move to approve the as written.
I second the motion.
Roll call vote. Timothy,
Aye.
Aaron,
Aye.
Mariah,
Aye.
Sandra, Oku,
Aye.
Susan,
Aye.
Erica,
Aye.
Dwight.
Aye.
Madam Chair, the motion passes unanimously. At this time, Madam Chair, we typically have time on the agenda for any public comment. There is nobody physically present. If there is anybody in the waiting room that wishes to make comment, you could raise your hand. No? Okay. So no public comment at this time. We'll have in just a few minutes, we will have the speakers. But I think we would have just enough time, Madam Chair, if it's acceptable to do C1 and do the Compact Commission and delegate updates on the next slide. And one note, we're gonna defer the annual meeting debrief. We won't have time to do that before the next agenda item. So we're gonna move that down when we're talking about some of the agenda items. But and the active rulemaking on the Compact Commission is one of our agenda items. But I wanted to check to see if Aaron, if you had any committee reports or updates?
Yeah, I don't really have any updates. I mean, other than for the Compact Committee, we had a meeting in October, and then we do have an upcoming annual meeting on December 10th.
Right. And that will be one of the things you'll be doing to discuss the rules, right? Yeah. And then Sarah? No updates on your committee. Anybody else have any reports out or serving on committees that I've missed? Okay, and then committee or task force reports out of the Federation? I think one of the things that I can highlight is there have been some additional materials that are being developed by the informed consent and sexual misconduct committees. Some of those have been highlighted, and a lot of the effort is focused more at students at this time, or creating materials that can be brought out and used by PT programs when working with their students. And the Continuing Competence Committee also met recently and were able to, we'll talk about the healthy practice tool, which the committee also works with the HRRI. They're also going through all of their reference materials and doing some updates and looking at things that have to do with jurisprudence examination. So I think over the next probably 6 months, we'll see more material coming out of that. I think another highlight from a task force that recently did their work and is going to publish some recommendations around animal therapy. And that will be relevant for your discussions, because that is one of the sections of House Bill 3824 to develop some rulemaking. So what I would anticipate is that is either from that task force or other speakers, we could bring in that information as part of your work and as part of the rulemaking process to inform that work. Those are the primary updates that I would have. Sarah, do we happen to have our, okay. have our speakers for on the agenda item D1, psilocybin services and dual licensure. And Sarah will switch over. And then I will ask our presenter who was unable to join us in person today is accessing remotely. So we'll give Sarah and the presenter a chance to get set up. And then Heidi, I will turn it over to you to do an introduction and then move into your slides, please.
Perfect. Thank you so much. Hi, everyone. My name is Heidi Pendergast. And again, sorry I couldn't be there in person. I had a daycare cold for my toddler that's taken me down for the past 3 days and figured I would spare all the healthcare providers in the room, but my apologies for not being able to be there in person. Today, I'm going to provide an update on Oregon psilocybin therapy program and a bill that passed earlier this year. I do believe I'm going to be joined by a colleague, a service center owner and facilitator who's also a licensed physical therapist. She might be joining in just a minute or two, but we can go ahead and get started and I'll call on her a little bit later. So next slide. So as I said, I'm the Oregon Director for the Healing Advocacy Fund, and we are a 501(c)(3) nonprofit organization working to support and expand state-regulated access to psychedelic healing for all who stand to benefit. Next slide. We currently operate in three states. Oregon, which passed Measure 109 in 2020, that legalized psilocybin therapy and established it under the Oregon Health Authority, who is the regulators of the program. Colorado, who also passed a ballot measure, and they recently just launched their program. And the most recent state added is New Mexico, and they have a fully medicalized program that actually passed through the legislature instead of through ballot measure. But we share best practices between these three states to share learning in real time because this really is a new groundbreaking program. Next slide. So what we'll cover today is talk a little bit about psilocybin therapy, the research behind it. We'll dig into Oregon's psilocybin therapy program, and then we have some legal updates for healthcare providers based on a bill that was passed in May of this year and leave some room for question and answer. Next slide. So Oregon's program really stands on the back of clinical research that's been done both in the United States and worldwide, but from places like Johns Hopkins, UCLA, NYU. The FDA has granted it a breakthrough therapy designation, meaning that it demonstrates substantial improvement above and beyond what's currently available. And so voters in 2020 passed this with, I think, about 56% of the vote in 2020, really looking at this as kind of a potential solution or a potential tool in Oregon's work around mental health. And I see that Jessica Reich has just joined the call. Hi, Jessica. I just got started on the slides, but if you could give just a brief introduction of yourself, and then I'll jump back into the presentation and call on you a little later.
Hi, everyone. I'm Jessica Wright. I am an OHA licensed facilitator, service center co-owner, and a licensed physical therapist in the state.
Thank you. Next slide. So there's a lot of research being done currently. There's clinical trials and just a lot of non-clinical trials and research actually happening on Oregon's program. I included this in here just to start thinking about what the overlap is for physical therapists and Oregon's psilocybin therapy program. I will share out all of these slides, and these are live links for people to find out more information. But there is a lot of research being done on psilocybin, both again in Oregon's program, but nationally and even internationally around phantom limb pain, cluster headaches, complex regional pain syndrome, fibromyalgia, and then there's some additional resources here. And there's a really amazing organization, Psychedelics and Pain Association, that has a lot of research and information on their website. Next slide. So before we go forward, I do want to say that psilocybin therapy is not for everyone. We do not see this as a panacea that can cure everything and fix everything. We see it as one tool in kind of an arsenal of different mental health tools or physical health tools for individuals who have a mental health background and family history background that this may be conducive and helpful for. There are certain cases where psilocybin we do not believe would be helpful at all based off of the data and research that we have. We publish a client education guide that has a lot of information on this, which I will follow up in an email with these slides and that guide so people can take a look and see. But I do want to say this because I know there's a lot of hype in the media nowadays about the potential of psychedelics. And while we do see there being a very high potential, there is a caveat that it is not for everyone. Next slide. So in Oregon's program, the Oregon model is highly, highly regulated. Access to psilocybin therapy only happens at one of those licensed service centers, of which Jessica is one of the co-owners of one of them. All facilitators are trained and then licensed by the Oregon Health Authority, but the service centers, the labs that test the mushrooms for potency, the manufacturers that grow them are all regulated under the Oregon Health Authority, and they have a department under their Oregon Psilocybin Services. There's extensive product tracking, client safety and support and transportation plans that are developed. And recently, there's been the passage of dual licensure and protection for healthcare workers that are participating in this program. There's no locating anywhere close to a school, no retail sales, no youth access, and no offsite consumption. So this really has been done in a therapeutic model. If we go to the next slide, I'll walk through what those steps of that model are. So when we talk about Oregon psilocybin therapy program, it's a three-step model. The first is preparation, and this is really intake and screening. Clients fill out an extensive amount of forms, which Jessica can attest to, and the client and facilitator decide if they are a good match for one another and if the client meets eligibility criteria to participate in the program. There are some things like if the client has had active psychosis, they are not allowed to participate in the program. That's one of the things that's contraindicated, but it really is to try to figure out if they're a good fit for one another and to go over all of the informed consent and rules around the program. The second part is an administration session. This is the session where a client consumes psilocybin at one of those service centers, and the facilitator is there to support them throughout the duration of their journey. They must stay at the service center for a minimum amount of time, depending on the amount of psilocybin that they've consumed, and the facilitator is there to help support them in that process. The last step is integration, and this happens several days after the administration session. And this is really the meaning making, where people bring the lessons from what they learned or gleaned from the administration session into their everyday life. Next slide. So to date, there are 24 licensed centers across the state. Mainly through the I-5 corridor, as you would expect during population centers. There is approximately 370 licensed and trained facilitators, and there's been over 14,000 clients through the program. With that, there has only been a severe adverse event rate of 0.1%. So that's 1/10 of 1%. And that definition comes from the OHA, and that's during one of those administration sessions, the number of times a person has actually had to call for emergency services. I think it's less than 15 total out of those 14,000, which is pretty impressive. There's also a link at the bottom here that will link to a safety page where the Oregon Health Authority has all of this data on their website. Next slide. So we've done a lot of work over the past few years in talking with both people inside of the program, facilitators, service center owners, and people outside, healthcare providers, clients. And some of the things that we heard are, number one, we heard that patients were going to their providers and asking, hey, I'm interested in this. Would this be a good fit for me? And their providers saying, I don't even know if I can talk about this. Or from provider's perspective, thinking that psilocybin therapy could possibly be a good fit for their patients, but not knowing if they're even allowed to speak about it. Additionally, the Oregon Health Authority prohibited facilitators from bringing skills from any other license to this work. So we had heard from folks who were registered nurses and were doing intake and had a very, very good eye for looking for people who might have physical or medical histories that wouldn't necessarily be a good fit, but they weren't sure if they could even bring their skills to that portion of the work. So there was a fear of engagement. Healthcare providers were being left out. And we really see this from a client safety perspective as well. And we want trained professionals in this program bringing their skills. Next slide. So in earlier this year, we supported a bill, HB 2387, called the Psilocybin Services Improvement Bill. And it was signed into law in May of this year. It adds legal protections for healthcare providers to discuss psilocybin therapy with their patients. And our program is not, in the state, is not a referral program. So clients don't have to be referred in and they don't need a prescription. Anyone in the state who's 21 years of age or older and who meets certain criteria would be eligible to participate. We also passed dual licensure, which I'll go on to in another slide. We had changes to the Oregon Psilocybin Advisory Board to require licensees on that board. We aligned the complaints process with other licensing boards to allow for confidentiality in complaints. And this is really to encourage people to complain if they see any misconduct in the program. And it also included stronger labeling and disclosures for additional psychoactive compounds in the mushrooms. Next slide. So now healthcare providers can discuss psilocybin therapy with their patients. They can get licensed as a psilocybin therapy facilitator without fear of losing their healthcare license. And they can use their professional skills specifically in those bookend sessions that do not touch the psilocybin whatsoever. And I should also say that at no point in the process does the facilitator ever hold or touch the mushrooms. It is a transaction between the service center themselves and a service worker there and the client. So they really are there as a support person. So facilitators on 7 named boards currently can use their professional skills in preparation and integration sessions. And if we go to the next slide, these are currently the 7 named boards. So there's the Board of Naturopathic Medicine, Nursing, Medical Board, Psychology, Professional Counselors and Therapists, of Licensed Social Workers, and of Pharmacology. Once this bill passed, we had several individuals reach out to us and say, I'm a part of these other boards, and we are very interested in having our board added to the list to be able to bring our skills and get clarity. And Jessica was one of the people who reached out to us and raised up adding physical therapy to this. And I will say that the boards that we've worked with so far have been incredibly supportive of this and have been working with us to provide presentations like this and answer questions about the program. But Jessica, I was wondering if you could speak for a moment just about your experience and why you think it's important to be able to have physical therapists be a part of this legislation.
Yeah, thanks so much, Heidi, and thanks everyone for having me here. So yeah, like Heidi was talking about, there's a lot of ways that having my physical therapy skills have really overlapped and aided in my facilitation. So, being able to discern who is eligible for services first off, being able to have honest conversations about medical conditions with people and really like understanding where they're coming from and what that means and what that's going to mean for psilocybin administration. Um, and also just, having the confidence and accuracy to be able to hold those conversations and to know when to refer to other people as well. So it's been nice having medical doctors on staff that have been in service and in rotation with different service centers around the state to be able to ask those questions to really make sure that people are eligible and aren't going to have any medical adverse reactions with this. Also, having psychiatrists and pharmacists on board too has been super helpful. So yeah, and then just being able to use my clinical skills to, assess for blood pressure and heart rate. So these are things that can vary when you take psilocybin and can increase. And that's one of the risk factors involved. That's the way we screen. And also what we talk about during our preparation stage of things. So being able to actually accurately do that and having clients know that they're, in safe hands when they come in for treatment too really helps. I think I've had a few people actually specifically seek me out, knowing my background in physical therapy, knowing I might be able to accommodate them, especially with people with chronic pain, fibromyalgia, different spinal issues. So it's nice to be able to really meet people where they're at and yeah, have people go through this really safe and as supportive as possible. Like Heidi mentioned, already Oregon Health Authority has been amazing at the safety and screening process and having this severe adverse reactions being at a complete minimum really attests to how effective this program has been. I've really been really appreciative of that for sure. So I will share a client story, and there's a couple of them that have been like pretty miraculous, but like knowing that that's the unfortunate thing about this too is, there's no guarantees with this. And, one person's experience doesn't necessarily mean another person's going to have the same experience. So again, being able to have that conversation with people and figuring out where to go from there afterwards, like referring to different services, whether it is physical therapy, or another kind of medical profession. So I had a client come in and not necessarily this was why he was coming in, but had severe carpal tunnel pain that was just chronic, wouldn't go away, and had a session where energy moved in and out through, and you felt it go up. And all of a sudden, after that session, the carpal tunnel pain was completely wiped out at that point. So there's a lot we don't understand about why that works and what that is that happens that way, but it's been pretty effective. I've seen it in migraines, I've seen it in fibromyalgia patients, and I've seen it in people with really chronic conditions. So it's really nice to figure out who's appropriate and yeah, just been kind of amazing overall. But it's not a guarantee. So that's the hardest part about it.
Thank you so much, Jessica. Appreciate it. And just one thing to note with this program and the way that this works is this wouldn't be any expansion of scope in terms of what physical therapists can do under your board. The person has to be actually registered and licensed as a psilocybin facilitator. And if there's anything that happens in the program that's related to psilocybin therapy, the OHA and OPS will investigate and look into that, and we'll have back-end communication with the actual board. So this wouldn't require any additional effort on the part of the physical therapy board, but would really just allow talented folks to be able to bring their skills, just as Jessica spoke to it. Next slide. And to reiterate here, so it would be able to bring your skills to this portion, to preparation, into integration here, and not the administration session that's at the service center itself. Next slide. In terms of who's using the program, the Healing Advocacy Fund advocated for Senate Bill 303 to collect data and information on the utilization of the program. And so this is some of the things we're starting to see. They just started collecting the data as of January 1st this year. So we only have about 6 months out of 28 months, I want to say, data, but that will be ongoing. But we've heard from groups like Heroic Hearts Project, who's brought over 20 cohorts of veterans through Oregon's program, that 35% of those veterans are seeking psilocybin services in part to deal with chronic pain. There's also just chronic pain and mental or physical exhaustion that we're seeing in terms of reasons for people accessing services. And again, this is a link for you to be able to dig in if you're interested on your own time. Next slide. So there are still a lot of questions around dual licensure. Healing Advocacy Fund has been working with a number of different law groups from across the country. We recently did a panel on dual licensure with Emerge Law Group, Vicente Law, and a law group out of New Mexico talking about dual licensure. That'll also circulate. We are making the road as we're kind of walking it. And so there are some questions that are unanswered right now in terms of insurance and things like that. But we do work with a team of legal experts and really try to be able to provide those resources to the broader community, not just in Oregon, but also in Colorado, who actually their program started with dual licensure. And this is one of the lessons that we borrowed and took back into Oregon. But I'll also circulate some of the resources that we've been working on regarding dual licensure. Next slide. In addition to the clinical trial research, there's a lot of amazing research starting to happen in Oregon's program. And this is the first time ever that real world research has been done on psilocybin therapy in the United States. And there's a group open that's based out of OHSU that is doing a longitudinal study on this, and they'll be publishing results early next year. There's a report from Bendable Therapy and Osmind, and then there's the Senate Bill 303 dashboard information. Healing Advocacy Fund has also been working on an alcohol use pilot, studying the effects on alcohol consumption with people who go through psilocybin therapy. And we will be, the researchers that we worked with will be publishing early next year. And then there's also been a really amazing study done by Dr. Matthew Hicks on low-income individuals with depression. And he has started circulating his results, and these are all links to that. Next slide. As you could tell, we are really paving the way for a safe, accountable program with transparency. I think adding additional healthcare providers into this program only strengthens it and brings a higher level of skill to a program that's been very, very well designed by the Oregon Health Authority. Next slide. These are a few participant quotes from the program. We'll go to the next slide because I know we're running short on time. And people can review this in their own time, but there really are the number of incredible testimonials are they're just incredibly, incredibly impactful. Next slide. These are some resources about the program. Again, links to the legal webinar, which I'll circulate, and happy to answer any questions if we have time for that.
Questions from the board?
I have a question. When is afterwards, what kind of time frame are you talking about? Like you're not talking about the same day and the same physical space that the administration takes place?
For the integration session?
Yes.
Yes, so it needs to be offered within 72 hours after the session, but it is not the same day. The client has to leave, go home, rest up, and then come back in. And the integration it's optional, but I will tell you, and I think Jessica can speak to this too, that it's one of the most important parts of the program. And a lot of folks offer multiple integration sessions. But Jessica, do you want to speak to integration and kind of the way that you all do it?
Yeah, that and preparation are super important because this is an experience that most people have never been through. It's kind of hard to explain what they're going to be experiencing, and it's different for everybody. So that preparation piece is super important to get people in the right mindset to be able to go through this comfortably and safely. And then, yeah, integration afterwards, because a lot can come up that, you weren't prepared for. It's kind of like peeling back layers of an onion. I like to liken it, going through what the root of the cause is. So sometimes there's a lot that comes up that people aren't prepared for. And so it's really, really important to be able to discuss this with number one, with your facilitator, but with whatever mental health provider you have too afterwards. And like Heidi said, it can be as ongoing as it needs to be for that person to get the meaning out of what just occurred.
And also, from talking to most of the service centers in the state and facilitators, they spend about 12 to 15 hours with a client total, doing multiple check-ins with them beforehand. The psilocybin session usually lasts probably at a max dose around 6 to 8 hours. But then there's additional time really before and afterwards that they're touching base, talking with the client and making sure that they're really set up for success afterwards.
So what does that look like with, for instance, one of your patients, Jessica, where they're being treated for something very related to physical therapy? How would that work and your role in that?
Yeah, thanks. That's a great question. So one of the reasons that I got into this was how this works between like connecting the mind and the body so much. And I feel like that's one of the biggest barriers in physical health and physical rehabilitation, usually are people's mental health barriers. So this is kind of a way to help break through those, to be able to like progress a little bit further. So, it's something like dealing with whatever barrier there was. Therefore, it helps them, enable them to be able to take the autonomy to kind of move forward and progress. And especially with the physical therapy treatment, I'd say this really works best for people who have been like stuck or at a sticking point in therapy, or you feel like maybe that mental health, is a barrier to the progression, and then we work forward with that afterwards, as long as that takes. Did that answer? Sorry.
Yeah, kind of. I'm still kind of like, if you could even kind of give a case history, that might help me. Like, was that your patient with the carpal tunnels?
Yeah, well,
Brought you to-
that's the interesting thing. That wasn't really what that person was coming in for either. So
Oh,
that was
okay.
kind of just a happy byproduct, which was interesting. So yeah, most often people are coming in for some kind of mental health reason, more than a physical reason. Lately, we've kind of been finding that it's an interesting byproduct of what happens and what occurs also during a
Okay.
psilocybin treatment. And just because, I've had to keep my roles very separate for this time, I haven't really been treating people in succession, but this would be like a beautiful adjunct, I feel like, to do that. So that's kind of the
Okay.
hope of getting the board on board.
Thank you.
Yeah, hi Jessica, this is Erin. I actually know you. Hi. Do you recognize me? Hi. Saw each other like
I can't
okay.
see. Yeah,
Erin Crawford.
Hi. Oh, Erin, hey.
So how do you see the board helping to support this, I guess, is kind of my question for you. Like, how do we help you? Or
Yeah,
what is it you're asking specifically for us to support?
Well, I think it's good to know when to have the conversation about this, and being safe to have the conversation with your patients about not feeling like you're risking your license to do so, knowing that it is a legal service to offer. So I'd say when you're noticing that maybe like the progression to therapy might be something a little bit deeper, or something that involves taking more of a mental health approach or look, this is kind of a fast track way to do that. People liken it to kind of, like 10,000 hours of therapy all in one psilocybin session. But this is also why it's important to know what to do with that information afterwards to carry it forward and help the person like progress as, best as they can after a treatment.
And if I could add, so Healing Advocacy Fund, we helped pass HB 2387 earlier this year. And what we're looking to do is add the Occupational Therapy Board and Physical Therapy Board into that legislation. So we have a proposal that's part of a larger healthcare omnibus bill that's being put forward by Representative Nose. That has some other smaller fixes in the program. Each year we kind of try to learn and see and add in different legislative fixes. And so right now that is included in the bill. We expect that it would, which we've been doing a little bit earlier, even before we submitted it. So right now that is in process, but wanted to make sure that we're answering any questions or if there were any flags from your all's part.
Heidi, this is Michelle. I have a clarifying question from the current version of 2387. The legal protections for healthcare professionals, does that apply to PTs, OTs currently, all health professionals, or is it only the ones named in the bill?
So in order to speak about psilocybin, that applies to everyone. And that's really for providers who are outside of the program. So they're not facilitators. That's if, a client comes into your physical therapy clinic and says, hey, I heard that this might be good for chronic pain. What do you think about this? You can actually engage in a conversation. But in order to bring your skills to the preparation and integration, it would need to be one of those 7 named boards. And that's where we're looking to add physical therapy into.
And it wouldn't be for the other boards, or if PT were added, my understanding is that nothing would change the scope of practice for the individual. So if somebody is going to PT and they have a treatment plan, any of that wouldn't be part of a PT plan of treatment. But the PT may recommend that the patient go and do this, and may or may not be the same facilitator. But then after the fact, that's obviously something in the patient's history that you can adapt your treatment plan. Right?
Exactly.
So it's
That's
like
correct.
a handoff and hand back, even if it's the same individual.
That's correct.
Okay. And the value of dual licensure is that there's something to be said for being able to work with the same provider through the whole process, wearing the different hats throughout the process, but nothing would be impacting the scope of practice under this board at this time.
That is correct.
And yeah, can I add? And it might even be beneficial to have two separate. So having your facilitator be separate than the physical therapy before and afterwards, and just get that continuation of care, but in that cross communication piece. We do like to communicate with as many providers as we can for the person, for that continuity of care for sure.
Hi, this is Tim Brinker, physical therapist. I'm curious in regards to my understanding is that Oregon allows this treatment to be provided. How does this fit under federal regulations?
So federal law still lists psilocybin as being federally illegal. So very similar to kind of cannabis, that even though, probably 20, 30 states now have legalized it, it's still federally Schedule 1 substance. So that still maintains. And so there is certainly risk with engaging in this program. The OHA has said that they have been in communication level. And part of the reason that this program is able to kind of sustain is it's so highly controlled within the state model. So we haven't had any issues with federal intervention or anything like that, and it really extensive product tracking. There's never been.
Heidi, I think,
Oh,
okay, there we go.
fine.
Your sound cut out for just a couple of sentences.
Sorry about that. But the OHA does actually talk to the feds about this and about how contained it is, and it's part of the reason that this is such kind of like a tightly controlled model.
So because it's a tightly controlled model, but still a restricted substance under federal ruling, is there funding or insurance coverage for this service?
There is not currently funding or insurance. Part of the focus in Oregon's program and part of what we're trying to do as well is to put additional funding into research for the program to demonstrate that this can be done so that eventually, hopefully, this can be rescheduled and that is a pathway. So a lot of folks are starting to look at Oregon's program to invest in research because you can do research in our program now at substantially lower rate than clinical trial research. And we believe that'll help build the case for federal rescheduling. And our team has also submitted numerous documents to Senate committees on psychedelics and things like that. And so part of what we're doing here, I think, is really demonstrating how this can be done at scale in a therapeutic way that benefits the community.
Thank you. I have another question is, as a physical therapist, if I feel that my patient has a mental health need that's beyond my scope as a physical therapist, my perception in my license would require me to refer that patient out to a licensed provider, which typically would be a mental health provider. And so how does that fit with this service? Because from my knowledge, I would be driving my patient or directing them towards a mental health provider versus a service such as this.
Mm-hmm. In that instance, if it's specific to your scope and that's laid out, I think it would have to go to the mental health provider. But I'm also looking to Jessica if you have thoughts on this or if you've kind of come into this in your physical therapy.
Yeah, that's one thing we ask about our clients is if they do have a mental health provider on board, because we are not that, and we are very clear that we do not offer that service to them. We do have that integration afterwards, which helps, and that helps the continuation, especially if like we need time to get a mental health provider on board. But yeah, that's usually the first question. So this is more, thinking about like if there's like some kind of mental block, if there's some kind of, and we know chronic pain coming mostly from the brain, if there's something like that you feel like is a block to treatment, that's more when you could most likely feel safe to direct refer to a service center, and then they will ask all those screening questions and be sure that person's safe. There's no diagnosis required to do psilocybin treatment. And again, it's just kind of being safe to know when to feel comfortable to refer and when it is appropriate. for a PT.
And I think if someone has kind of if you're seeing that they may have, more severe mental health things going on, I think at that point we're referring to a mental health provider and they can have that conversation with them, versus just kind of the stuckness that Jessica had referenced.
Thank you.
I was just, my name's Erica. I was just curious about like typical number of treatments for someone and then how they are currently paying for that
Yeah.
service.
Yeah. Heidi, do you want to take it or? Okay, I did. So typically we hope it's one. You hope you have one session and that's enough to break through for whatever thing you're going there for. Realistically, it might be a couple, but that's also why we do hope to adjunct with other professionals and other services that can help people along after a psilocybin session. The hope is one because it is expensive and it is an out-of-pocket cost. And that is definitely one of the biggest risk factors or the cost, benefit factors I'd say to this is that we have had people successfully use their HSA or FSA accounts, especially for the administration side of things. That's one way. And there's different facilitators that offer sliding scale and different discounts, and especially based on different conditions. So, yeah, that is kind of a barrier at this point, but there's kind of hopefully a little bit of workarounds that we give.
There's also an incredible group called the Cherie Eckart Foundation, and they offer scholarships to individuals, and have raised quite a lot of money to be able to give this to folks. And there's different groups that they are funding to go through, and I'll send that information over as well. But it is cost prohibitive as anything that someone's spending 12 to 15 hours with kind of a professional to go through. They start, individual sessions generally start around 1,200, and I'd say the average probably is like 2,000 to 2,400. That's kind of the range. And again, that's the like 12 to 15 hours spent with the facilitator, and that's all in. So it's not insignificant at all. We understand that this is out of reach for a lot of people that stand to benefit. And we also know that anytime there is kind of a new product or a new therapy, that it starts oftentimes significantly more expensive, and over time, we're able to lower the costs, and that's really our goal with this.
Mariah Frank, PT. How many hours of training do the facilitators have?
I want to say the latest one was at 140 hours.
Yeah, that's
and
right.
then
And then there's continuing hours on top of that every year that we have to go through.
yeah.
But yeah, there's a very specific training program and protocol.
Mhm. And then a practicum that's involved after that.
I guess I'm still a little unclear about the ask. Can you hear me okay?
Yeah, this is
Informational only.
This is informational only.
This is-
yeah, it's to
yeah.
make everyone aware that there is a proposal in the legislature right now, or that will be submitted as part of the short session next year, to include the physical therapy board as one of those 7 named boards.
And because this board is named, we thought it would be good to bring them and give you guys a backgrounder on it. When the bill is introduced, you can discuss that as far as if you have any questions. I presume since we're being named in the bill, we would also, NOS would ask us to come and testify potentially, so that we have that awareness as early as possible.
And I'll see if there's any other comments or questions or things that come up along the way. My door is open. We're happy to discuss. I'm sure there'll be some things that we don't have answers to yet, but that's part of the process, and engaging great folks like Jessica to bring her expertise into this. We're happy to be able to do that.
Other questions? No, Heidi, Jessica, thank you for being here today. Heidi, feel better.
Thank you very much.
We
The
feel for
teachers
you.
on the side over here. Thank
Yeah.
you for the opportunity. We really appreciate it.
Yeah, thank you so much, you guys. Appreciate it.
Thank you. Madam Chair, if it's okay, I think I'd like to have the board consider item D2, the workforce survey increase, and then come back to the C questions. Sarah, I think when we get down to D7, we'll incorporate that. So page, please, number 74. And you can jump to 75 for the document itself. Item D2. Yeah, for board members, I think with Heidi's slides and some of the additional things for display, our packet that Sarah and I have is a little bit different. Yeah. So what I wanted to, we had sent this out in a news brief to licensees. I don't know that this was, that we were aware of this or mentioned at a prior board meeting. The Oregon Health Authority Workforce Analytics Division has put forth rulemaking to increase the fee that healthcare professionals pay on renewal. And the background section on the document that's on the screen now, this is text that's taken directly from their notice of filing of administrative rulemaking and their language on it. But essentially, the program hasn't had a fee increase in a number of years. Operating costs have gone up, and so they're proposing an increase. What I do want to highlight, because the way they frame things, is that they're saying the new fee is $4, but that is per year. Because physical therapists have a 2-year license, there's the twice, so it's $8. It's been $4 for board licensees. That's going to jump to $8. Bottom line, then, licensees are paying $4 more to renew their licenses this period. When we do a rulemaking review because of their rulemaking, and my understanding is the hearing was on the 21st, the public, or the hearing was earlier, but the public comment period closed on the 21st. When I spoke with them earlier this week, they indicated that they were working through their process and anticipated filing the permanent rule today with the effective date of January 1. And that's why it impacts us almost immediately with renewals. The rulemaking for this board is not required like it is with some other boards. Because of the way your rule is written, you reference, in essence, their statute and the relating rules, which is where the fee is enumerated. And the bottom of the page just outlines the breakdown for PT and PTAs of the various fees that they will see, inclusive of that, what is a $4 increase. So these two numbers you see, the 233 and the 161, are each $4 more than they were last renewal period. So this is informational. There's no rulemaking that's required, but I did want to make sure the board and, of course, our interested parties are aware of this. And we've sent out one news brief, as I mentioned, but we would also be communicating this as part of the renewal to let folks know so that they're prepared and not surprised when they fill out their piece. I will say that the survey is mandatory to complete, but in the completion of that, individuals have the option not to respond to one or more specific questions if they're not comfortable doing so. But they have to go through that process by law before the board is allowed to issue a renewal. Um, Pause for any questions. Next item then is a focus on renewals. Go ahead and skip to document page. Again, we start with some background. We have a fixed biennial renewal cycle. March 31st is the date of expiration at midnight that day. We do open up renewal prior to that. This year, we're targeting, which it'll at the end of the document it lists, but we are targeting the 5th of January, which is the Monday. Part of that is where the New Year's holiday falls on a Thursday, and then there's a Friday. So we're targeting the 5th of January to open up the renewal process. Let me get back down to that. As board staff, we meet and evaluate after each renewal. We go through all of the feedback that we've received from individuals that have gone through the renewal process to see what worked, what could be improved. And in the process, when we look at that, we now have we've had 3 renewal cycles that have effectively been online in the new licensing system. And in 2020, as you may recall, was things happened differently with the pandemic. We extended the renewal deadline. We didn't initially require upload of continuing competence requirements certificates because it was a new requirement. So it was sort of a first foray into the new requirements. In 2022, we also saw the introduction of new requirements around cultural competency. There was a change in the way pain management courses needed to be completed, not just on initial, but kind of an ongoing basis. And all of that happened because of when the legislation went into effect almost immediately at our renewal period. So the decision this board made at that time, given one of your strategic planning pillars of prevention, is to have board staff manually evaluate the continuing competence uploads and then reach out before approving the license to let folks know if they're out of compliance. If they took a course that didn't qualify under, they took the wrong pain course, they took the wrong non-qualifying cultural competence, or the certificates were unreadable, anything to help them be successful in using the system and avoid an inadvertent violation for not completing C before the end of the renewal period. And we did then continue that in the 2024 renewal process. So when we're looking at like how things have been going, at the time, we sort of in an ad hoc, those of us that were doing renewals took tabs of how many people we were having to go back to, like if the application wasn't ready or complete on submittal. And we were seeing roughly 30% of applications had initial errors or were otherwise incomplete, meaning maybe they missed the OHA survey and we had to go back to doing them. During 2024, that dropped to about 9%. And 1% of that is folks that would need a manual review anyway, because maybe they had a declaration or they had a question. So issues on continuing competency is closer to 8% in that 9%. So then we began to look at, because some of the feedback is people expecting when they press submit that they can then print their license. And we got some feedback that some folks, and not just at the very end of the renewal cycle, but even in the middle, they were wanting their renewed license because their employer was requiring it, or they were going through a certification process and they needed the license to extend beyond just another month. And the delay between when they hit submit and when we did our manual review and approval sometimes was a surprise and sometimes it was an impact for individuals. Now that we have somewhere between that 300 and 500 individuals that have compact privileges in other states, they have to renew their Oregon license and have that processed through our system to the Compact Commission system before they can renew their compact privileges. So there's also that additional impact that has grown over the last 2 years. It was also very time and person intensive because the way we were able to do that was essentially at the end of the regular shift to continue into evenings and weekends to work on renewals. So we wanted to look at that in more detail, and thanks to the fabulous efforts of Sarah once again, looking into our system, looking at different dimensions. One is the time of day of renewal submission. And unsurprisingly, given that we have folks with organ licenses, frankly, around the world, in 2024, half of the renewals were submitted outside of that regular Monday through Friday, 8 to 5. I'm sure that's not a surprise to anyone because it's hard when you're in the middle of your clinical workday to renew your license on top of that. Now, you could say, if you go to the next left-hand graph, time from submission to approval, we still did a pretty great job of processing it, where most of the things were done within the same day, the same 24-hour period, and very rarely did we go longer. But it can still happen that on an individual basis, somebody could submit an application maybe before their shift at 5 a.m. We don't get to it until 9 p.m. And that's what the next graph over gives you a little more in that first 24 hours, the bulk of things that we approved. Arguably, the majority of them are, 4-6 hours or more before we can approve it. So when we look at all of that, given that we only have 9% or less of the population that runs into errors, and given that we have such a large percentage of the population that is fully complete on submittal, and that a large percentage of those individuals are submitting off hours, I'm not sure that the current way we were doing things is necessary or providing the kind of value to licensees that we want to. So the recommendation is that we would modify the licensing system so that it verified payment was complete. It would verify that the OHA survey was complete. And it would verify the submittal of the requisite hours and the requisite categories and that a certificate of some form was uploaded. It would not be able to do the verification of the validity of the submitted courses or certificates, but it would just make sure the numbers look right. There's something that's been attached. It would test for that. And then, of course, they filled out the other pieces of the renewal. The system would automatically approve the license. The licensee would get the notice, and then we would get the notice that a renewal has been processed so that we could spot check that. What we are recommending with that is that, and then related to that, anything that has a yes to a declaration, if it's already in a lapse status or if they're paying by check, anything like that, it would go to a manual review automatically and notify them that that's what's happening. We would still perform a CC audit on a spot check basis, but not before that point of submittal. We would do that within a month or two of the submittal. So we would start doing that during the renewal period, but when March Madness kicks up, that review could extend into April and May, but we would still go back and do that spot check on the submittals. And we would also do a spot check on the automated process to make sure that we don't see any glitches in a missing OHA survey or a declaration that got missed. But that would happen after that automating of 91% of the renewals that are submitted. The dependencies, and I referenced this before, with this change, it is dependent on change requests with the IT vendor to shift it from the way it was. So if they aren't able to complete what we need, then we can't do this without the system change. So there is that risk. Uh, we have been given assurances that it'll be done before the beginning of December, or at least in December. So it should happen, but we're not hatching our chickens yet. So we may have to plan to, if the board is okay with this process change, and we move forward and something happens at the vendor level, we may have to punt and either operate the way we did last time. We could still speed up our process a little bit by doing the audit after the fact, manually approve and do the audit after the fact. So we can speed some things up, but I'm would like to think that that can move forward, or if they're not quite ready for January 5, it's something that could get turned on mid-process. But that is a risk and that is a dependency. And then the final note, just to repeat that the current target is open for January 5th. So we wanted to present kind of the thinking, the plan for renewals, the status on that, and to make sure that the board is comfortable with that approach that we're recommending. Yes, ma'am.
Can you hear me? Yeah.
Yeah, you just have to get in.
Yep. So just to be clear, so I understand that previously you would maybe see that somebody didn't complete the correct courses for pain management before March 31st. And so you would get back to them, they'd have time to take the correct one, and that would avoid some
But-
kind of.
Yeah, because the board has a rule that if you don't complete the requisite continuing competence courses within the certification period, then it's a violation. And once the certification period is over, then it's sort of a de facto, there's nothing, you can't go back in time. And so that was, particularly with all the new requirements, that was our trying to help them be successful. And when, it's 30, 40% of your population, that's helpful. When you're only benefiting the 8% of the folks, then there's other negative consequences to that labor-intensive process.
What will happen to somebody, let's say somebody goes through and, doesn't get caught till afterwards, then what happens? Do you still do remedial stuff with them, or are they in violation? Or how's that gonna be for an individual licensee that makes a mistake in the renewal process?
It would be up to the board to consider if there is a violation and kind of what process that would be. So there would be a case that would be opened up with all of the case information, and that would be brought before the board as far as what the consequence is. There is, I believe it's one of the matrices in the rule that talks about like the potential penalty that would apply in that case. And that's part of why we would start the audit earlier in the process. But the same is true. There are quite a number of folks that wait until the very last day. And even with our older process, if they didn't have everything that they needed, they were in that position. Part of what we did last time, also in large thanks to Sarah and Gayla and Sherry, is the development of the training materials, the videos on how to do it, reference documents, and then we regularly send out renewal specific updates on what's required, what you need to do. Contact us, even in our auto replies if somebody writes us, key tips to try to help folks be successful.
Yeah, I guess what I was thinking is like, what if it is like they think they have their license done? Because this wouldn't have happened before when you were spot checking everything, which I agree is really intensive. But if it gets picked up later, then what? Will there be confusion with individuals going, oh, but I had it all taken care of. I've got my license here printed out.
There's no impact to the license. So once they, have complete the renewal and meet all the renewal requirements for what they've submitted, then at that point, they are issued that renewal license. If it's determined that there was something that was, so let's say there's a unreadable certificate after the fact, that's something that they can correct. If it's something where they took a class that wasn't qualifying, we could work with them to see, was there something else that does qualify? So there would be that work with them. They still have an active license the whole time.
And I guess the hope is that this time, since we went from 30% to 9%, that it's going to be less.
I think so because it's not new anymore to most of the population, right? You know, that the requirements are there. We've had the videos and the documents out there for a number of years. Obviously, we have brand new licensees who it's new, but we are there to support them as well. Um, there, no, as long as the board is okay with the direction, there's no specific vote that's needed on this item. Staff would just proceed in this direction to implement these process changes in this approach.
Concerns or any other questions? Seven minutes. Oh, 7 minutes. Okay. The time is 10 a.m. and the Oregon Board of Physical Therapy is in recess for 7 minutes. Okay, guys. Sorry. The time is 10:09 a.m. and the Oregon Board of Physical Therapy is back in public session.
Okay, on the next page of the packet, we are still on item D3, but a different focus here. What we wanted to do is a delegation review for items that relate to renewals. And so what you have here are, if you go through the Division 35, which is the continuing competency piece, I went through and found all of the references that relate to something that the board does. The board may approve this, the board may do that. And tried to highlight in yellow that reference to it. Then all of those items in the first part are items that are currently delegated in the delegation authority letter, I believe last reviewed in September. There is one item that in 848-03500-207, this has to do with a request for waivers for extension of time to fulfill or full waiver of the CC requirement in certain conditions. That is something that is still at the board level, something that you don't have in your delegated authority letter. What we then have from the delegation authority letter itself is I brought in, Sarah, can you close that door? The items that relate to renewals in general, which is number 4, which is kind of the administrative processes like we talked about, and checking for the validity of the completeness of the renewal application. And what we referenced as far as continuing competency audits, which is lumped with background verifications on license renewals. And then 15 is the line that relates to those continuing competency credits, courses, written special requests, activities. And what I've done there is just to illustrate that staff does not have the authority currently to grant those waivers or extensions. That would come to the board. But I framed it in, if you wanted to also delegate that to staff to process during renewals, then you would need to make that change, or we would bring it to the board. So I put all this up here. Of course, you can also change the delegation if you want something else that's currently delegated to come back to you during this process. Part of the reason these delegations are done is it's such a volume, and we only have a January meeting typically, and then a mid-March meeting. So there's limited opportunity to bring things to you during that process. But anyway, here's the background information and for board discussion of how you'd like to handle delegation. You can leave things as is, or you could make any of the changes.
Board staff want any changes?
I think that if you're comfortable, I think being able to grant the waivers or extensions would be worthwhile, only because of the timing of it, so that folks aren't having to wait to find out if the board is willing to do that. These are situations where folks, there's a lot of stress or trauma involved in the folks that would qualify under this being, so to not make them have to wait. You could do a full delegation, or you could also set, like by policy, certain criteria, where if it meets this criteria, board staff can do it. If it, in other cases, the full request would come to the board. So you could change the delegation, and then you could establish a related policy, or you could word it that staff can grant an extension of a certain amount of time, but not a waiver. So this is just purely draft on that. But for the benefit of licensees for the process, we get very few. We get maybe 2, 3, 4 a renewal period. So it's not that many, but it's more a timing of when the meetings are and when the renewal comes in.
That's what I was going to say, very few people, especially for the waiver.
I like the idea of granting you the authority for a waiver or extension, say like 60 days. And I know that if there is an extreme case, you would be bringing that to the board. You know, it's unclear.
Yeah, and I think I would, for this, that would be something that we would bring to you, a report out on if any waivers or extensions were granted under delegated authority.
Even right now, the things that we can do, if I feel like if we all look at it and say, well, I don't know about this, I'll bring it to you guys anyway. The ones that are already delegated.
My recommendation would be give you the authority to do that.
Move to modify the board.
I think what you could do to the motion, if we note for the record that what you want is to amend line 15 of the delegated authority to specifically say, or grant waivers or extensions. Well, let me clarify. Is the board wanting to delegate an outright waiver of the requirement? That would be like not where you don't, they don't have to complete it at all. The extension of up to 60 days makes sense, but a waiver would be forever and always. Yeah, you could like edit the language, or we could modify the language to remove grant waivers and have it read or grant extensions up to 60 days. That would still go to a board meeting. I don't think we had any outright waivers in 2024. We had some folks that wanted the extension. We did have an extension of 90 days, I think it was, and another one where they wanted longer but finished up. I would probably, it depends a little on when they're requesting it in the renewal process. 90 days would give them sort of almost the full quarter after to complete it. But it's what you're comfortable with.
Yeah, is it situations of like people being ill that we see the most because someone hospitalized or?
That's usually what someone's been ill in the hospital, out of the country, not access to cheering on some medical team in an
Or
yeah, it's usually medical stuff, or
it's usually medical stuff or hardship. We have had an instance where financial hardship um, for the individual who was unhomed at the time. Then it's been a while, but at one point we did have somebody who was deployed. With that experience, I think that was a request for a waiver because they just. But most of the time, it's a temporary medical. I don't think we picked that up on the mic. Can you repeat that, please?
I feel comfortable with 90 to make it easier for staff and licensees to work these issues out. For your delegated authority to last for 90 days.
I'd prefer to see it say with a duration of up to 90 days based on your assessment.
Yes.
It was like that, if somebody needed a waiver for those circumstances you mentioned, that would be brought to the board.
Yeah, if you're comfortable with the extension of up to 90 days, then we would strike grant waivers. And since that's not delegated, that would need to come to the board. We could aim for the scheduled board meetings, but it may mean if there's a situation because of timing where somebody needs you to view it, we would call a special, probably phone meeting for the purpose of that review of that waiver.
Are you ready for a motion? I'll try.
And I think, Sandra, what you could do, if we note for the record that the document as written is striking or grant waivers and being written to say only to add in line 15 or extensions of up to 90 days, then your motion could just reference as modified.
Okay. I don't need to say how it's modified, just say as modified.
Yes, ma'am.
Okay. I move to modify the board's delegated authority letter as modified.
I second the motion.
Roll call vote, Timothy,
Aye.
Aaron,
Aye.
Mariah,
Aye.
Sandra,
Aye.
Hoku,
Aye.
Susan,
Aye.
Erica,
Aye.
Dwight.
Aye.
Madam Chair, the motion carries unanimously. Okay. Okay. All right. Next item, I am going to do a presentation on the Healthcare Regulatory Research Institutes, or HRRI, Healthy Practice Resource. This is a HRRI is an organization that is a spinoff of the FSBPT. That's a wholly separate research organization that was created to address a dearth of research, particularly related to physical therapy, occupational therapy. A lot of healthcare research tends to focus on nursing, physicians, and HRRI was created to facilitate seeking out researchers to do the work in this area. One of the domains that was identified was practitioner wellness, particularly coming out of the pandemic and the numbers that you see on burnout overall. And through that, next slide, please. Perspective was that one of the ways to promote public protection involves supporting and sustaining the healthcare provider's well-being and healthy practice through not only continuing competence, but the ongoing self-assessment or self-awareness of that. Part of that is seeing instances of violations worldwide, really, where one of the contributing factors is the individual's wellness or level of burnout or vicarious compassion fatigue, those elements that we've talked about over the years. So HRRI sponsored the research to develop and validate a self-assessment tool. The link on the slide is to that published work where the psychometricians and the researchers got together to develop that mechanism that would be a valid assessment in the different domains. Next slide. So the resource itself is, and the link on this page takes you directly to the assessment information, but it includes 10 modules at this point that focus on emotional, mental, social, financial, physical well-being, as well as elements that have to do with workplace and practice climate and compassion. And go ahead and go to the next slide, please. What you have on this slide is a screenshot of the 10 modules that are broken into the two categories, the work environment and the personal life. The other sort of tenet of this self-assessment tool is that it's no cost to complete any of the modules. It's completely confidential. The results, if you complete any module, only go to you. If you choose to print out your results as a PDF, then it's yours, but it's not retained on the system in any way. It's not shared with any regulatory body whatsoever. The it really is intended to do that self-assessment and to have the individual have the opportunity to do some self-reflection. And so part of what is available on the back end are some publicly available learning resources that when you complete the assessment, if you score in a particular way where the assessment tool feels that a particular resource would be useful, then it would make that recommendation. But individuals through the website have access to all the learning resources, even with after even if they haven't saved their results. There is an optional ability. Each module has been determined to be valued essentially at 1 credit hour, or 1 CC in our language, and a qualifying certificate is issued. The FSBPT sponsors for PT in validating that certificate. So under Division 35, under your rules, this would be a qualifying activity. But it is optional. The individual has to at least put in their email in order to get the certificate. But again, none of the assessment itself is retained. Next slide. This is just a snapshot. I went through and made up answers under the job security, insecurity module. When you get to the results screen in all the modules, after you go through the sections, you'll see this screen that gives you the sort of a sliding bar take on that and a brief summary of recommendations. And because it's a screenshot, at the bottom of that screen that that you don't see would be the listing of resources that I referenced. Okay. Next slide. So in reviewing this tool, looking at your rules currently, Oregon does have a non-clinical course or activity that folks can take up to 4 hours from any single category in the A through D there. And so based on staff review, Sherry completed many of them. And in talking with HRI staff, these would fall under personal development self-care, but not under business leadership, professional conduct, because it really is, even in the work environment places, it's really more focused on the individual's position or role or level of satisfaction in those climates, as opposed to something that's more of a business or a professional development piece of it. So we wanted to bring this forward. It is a free resource. It could be CE available for licensees in Oregon. I don't think I made it perfectly clear yet, but it's not targeted just to physical therapists. It is designed in such a way that any healthcare professional, frankly, any person could complete any of the modules. And the survey, when you do go in, it does ask you to disclose what health profession you're associated with. And the reason it does that is because if you opt for a certificate to use for continuing competence credit, right, it links it to that profession on that. HRI has been in conversations with other organizations related to physicians, nursing, social work, psychology, and talking to them about what might work for them. And I will also be talking about it with the other health boards in Oregon next. But bringing it here, we wanted to bring some awareness of the tool, bring some the analysis of how it would qualify in Oregon. And then next slide, just if the board wanted to have any discussion or what you would like to do with this. The one call out, the resource library is going through an update right now because there are some things that were initially identified that got moved behind paywalls because they're publicly available. So their staff are going through and identifying which resources those are and replacing them with other viable resources that don't have paywall so that the whole tool and resource library is free and accessible for licensees. So with that caveat, I would open it up for kind of any questions or comments, or to what extent the board, because we could put this into news briefs for licensees. We could effectively promote it during the renewal season because of that. So just open up the floor.
You know, is it widespread in other professions or employers promoting this at all? Do you have any sense on how much momentum it has in Oregon?
Not in Oregon. What I can say is that it's been presented at a number of national, it went to the Federation of State Medical Boards. It's gone to CLEAR, which is a broad, not just healthcare regulation, but regulation overall. And that's an international conference, and there's been significant interest in it across all kinds of professions. Wisconsin is looking at it at sort of a state level. And it all ties to burnout, particularly in healthcare, is so predominant and tied into, again, your strategic pillar of prevention, something that can support the licensees. And it was designed specifically to not require or not share any of the information or require disclosure at all. It really, and the reason for that is that in their research, and it's kind of not surprising that if somebody else is going to see the results, you may not be as honest or self-reflective. And so it really is designed to be a personal benefit, so there is a hope that individuals will use it, that they'll get something out of it. From a continuing competency standpoint, there's always the risk that one person may not get as much out of it as the next person. But the hope is that it can help people have a better sense of that. I will say that when it was first being developed, I did the work-life balance module. I will say it was enlightening. So I can personally attest to getting value just even in testing out the module.
I would say the good thing too is if it's promoted that there's no cost to it. There might be people who take it just because of that, because it's free. And then once they get in there, they're like, oh, this is kind of interesting. Like I know I had to just become a healthcare provider for my parents, right? And I have to take this mandatory training. That was like, ugh. And then once I got in there, I'm like, this is kind of good, So I think, if people just get in there for that purpose only because they don't have to pay for it. And then once they're there, you're going to do it anyway. You might as well pay attention and get something out of it. I think, even if some people got a lot out of it and some people got a little, the people who got a little is still enough. It's still valuable.
It would meet all of the criteria of up to 4 hours only. I don't know about Oregon yet. I do have a meeting with the other boards next week. It would depend on how their rules are written and whether they have something equivalent to what you all established. I know when you first established this rule concept in 2018, 2019, it was a new approach to have non-clinical qualifying courses in Oregon. Things may have changed since then, so I'll have to update my knowledge. And then if we look at PT boards nationally, there are roughly 10 at this point that have identified that their current rules would allow this to be approved in their jurisdictions now. And then there were several other states that are interested in exploring a rule change to allow it.
I I'm in favor of promoting it so people are aware of the option for multiple reasons. That there's no cost and that it's just a really good resource that I don't know how people would find without some kind of like, hey, this is yeah.
Think that a lot of larger organizations are using a tool similar to this to assess the health of their workforce. Yet that is the benefit of the employer. It doesn't benefit the individual. And this would be something that, for us to help the health of our professional clinicians, this would be a great option.
Oh, just wondering if this would be something that we might mention in a advisory letter? If
Yes. Absolutely. I think it, all throughout our interactions with interested parties and licensees, that it could be benefit if that we could make that recommendation. There also there's been interest with PT schools and use with students, in part because anecdotally, some educators have identified that students are already experiencing some, anxiety or potential burnout just through the program. I don't know. And to get them used to being self-reflective and to think about this work-life balance before they even get into the professional licensed. Yeah. So it is also something that we could add when we go out to the programs to meet with students or to send out to the programs for them to use with their students. So we can also push it out that way as well. I don't know if you already reference it yet.
We haven't referenced it, but I was also thinking, I put in to present also at the APTA's meeting, which I think is in February, or March. I could mention it then as well, because I think a lot of students go to that. So I could mention it when we're there. And also we could ask to put it on the APTA Oregon's website as well. Just they put a lot of things from the board on their website.
And it is APTA National has been involved in the development of the process, and they have a landing page, something that, to the effect of practitioner wellness. And so there are cross references at the national level with the association as well. Okay, I think with that, we will move forward and look at ways that we can promote this, particularly during renewal, but then also explore ways that it might be beneficial during the investigative processes and student outreach or general outreach. Don't interact directly with employers all that often, but if and when we do, we can also that way as well. Okay, item D5, we're going to shift to possible rulemaking related to compact privilege. And next slide, I think, dig into the document. That one you're on. Yep, yep. Page 89. All right, for context, we are looking at a potential fee, and background on this is that when somebody purchases a compact privilege in a jurisdiction, the fee is part of it is paid to the participating state, the member state. Part of it is retained by the compact commission, and then that 1 + 1 equals the total fee that's paid by the compact purchaser. So in Oregon, the fee is currently $50 for the state fee, there is a $2 fixed processing fee that the commission retains. So what we net, if you will, of that $50 is $48. And the Compact Commission's fee is 45. So an Oregon privilege right now is $95. This fee was established before the compact was really even established. We were the first state to pass the compact legislation. And the way that legislation worked is that the compact didn't become fully operational until 10 jurisdictions had passed the statutes. And that happened in mid 2018. So between the passage in Oregon with the statute in 2016, when the fee was, it was in this period that the fee was being modeled. And it was based on the estimate of what there might be a revenue loss, if you will, if folks weren't purchasing endorsement applications into Oregon, the fees that need to be paid to the compact itself. And all of that was calculated and sort of an estimate on what we thought at the time the level of effort would be for processing compact privileges. The concept was that it would be mostly hands-off at the time. That hasn't really proven to be true. So not only have all of our operating costs increased, but since it was established roughly 10 years ago, we looked at the data that I showed you on investigations and those rates that was not part of the initial modeling at all. We also, because in the interest of providing public information, we do enter the compact privilege holders information into our licensing system, so it's available for lookup in one place. So the initial concept was they wouldn't be entered at all. We wouldn't have to process anything. We in fact do. There's obviously not as much review as there is for an Oregon license because you're not looking at the other pieces, but there is that element of it. And there's a little more detail there. Then what you go in is a chart of what the other member states have established, which ranges a lot from nothing. And part of that is, I know in Arizona, they have some restrictions on what fees they can charge, particularly if it's not something that is Arizona issued. And the total fee up to, if you scan to the next page, at the top, you can see, I think it's District of Columbia is the 264 for DC. That is the cost of their application. So what they did is they wanted to be loss neutral. And so they set those fees the same. I can also tell you that unless somebody had like a statutory requirement not to charge a particular fee, what you see a cluster around that $50 where Oregon is currently. That's because Oregon was one of the first. So a lot of folks started just modeling the same fee as they rolled on. And then the higher cost ones tend to be states that came on later that had more information available to them when they were establishing fees. All of that is the background for the recommendation that staff is making that we mentioned, initially, maybe at the tail end of last year into the beginning of this year, when you were looking at budget and the potential need to make this change. We are recommending that you consider increasing the state portion of the fee to 102, which is, it is a jump, but it's been almost 10 years and things have changed. That would make the total compact privilege fee $147 for the individual. And we would receive only $100 out of that process because of the $2 processing fee. What is listed then next is for references, the verification, meaning the fee that both the PT and PTAs pay for initial application, the 187, and then renewal fees, 200 for PTs and 130 for PTAs. Now, these numbers are without those other verification and other fees, background verification, workforce survey tool, because compact privilegers don't need to complete that right now by statute. And then there's the credit card processing fee. We don't take their credit card, so they don't do that. So to make it more apples to apples, that's why we're listing the number these ways. But the current application fee ends up being $250, $263, Gayla? $250 with all the fees. If you want to make this change, there's rulemaking is required because this fee is specified in the rule that's listed on the page at the bottom here. If you wanted to initiate the process, then we would notice it, go through the public comment period, and it would come back before you at your January meeting. If you were to adopt the rule at that time, then it would be effective February 1st, or whatever day next makes the most sense in a work week. You could also make the number be different. Will this recoup the full costs? No. There's a little bit of a balance in this recommendation with where other jurisdictions are and trying to fund what it costs to administer compact privileges, but try to keep it in line or keep it reasonable.
Why wouldn't you want to recoup all your costs?
I think part of it is a volumes game. The volume keeps going up, and the more volume we have, the lower the individual fee needs to be. I think that this is something we probably want to look at every biennium and not wait another 10 years and make adjustments. So possibly.
Okay.
But I think as like a first step, this is reasonable. It does anticipate that there'll be some more volume.
So you're saying it would be the 187 for both PTs and PTAs?
It would be 102, but it would end up being the 147. For the compact privilege, it would be the same cost. It's the same cost now in Oregon. So this would jump from $95 to $147 for what they pay.
Okay.
And for us, it would jump from $48 to $100 in fees that are paid, revenue.
Appreciate the volume costs and the support conversation. So at 147, not counting the complaints we've gotten from the compact, does that?
I don't know that I have a specific answer to that question. It gets us closer to that. There are a lot of variables. Some cases cost more than others. And part of what a license fee in general does, right? You never know what types of cases, you don't know what will go to hearing, you don't know how much all of that, right? But if we sort of like take a guesstimate on that, I think where we'll end up then, given the kinds of complaints, it'll get us closer to closing that gap.
Other questions or comments?
Yeah, if the board is interested in pursuing this, then we would need a motion to initiate and comfortable with the amount proposed, then to initiate.
In the motion, do we need the amount?
No, if the board is comfortable with what's on the screen, then the motion could be as written.
Okay. I move to initiate the administrative rulemaking process to modify OAR 848-005-0020 parentheses H as written.
I second the motion.
Roll call vote, Timothy,
Aye.
Aaron,
Aye.
Mariah,
Aye.
Sandra,
Aye.
Boku,
Aye.
Susan,
Aye.
Erica,
Aye.
Dwight.
Question. Sorry. Is it 1H?
One in parentheses, H period. It's written differently.
She didn't say 1H, so I didn't.
Yeah.
I was just making sure it was correct.
Thank you for that. It should be 1H. Probably revote it with a, yeah.
I need to restate the motion. I move to initiate the administrative rule marking process to modify OAR 848-005-0020 parentheses 1 parentheses little h as written.
I second the motion.
Roll call vote, Timothy,
Aye.
Aaron,
Aye.
Mariah,
Aye.
Sandra,
Aye.
Boku,
Aye.
Susan,
Aye.
Erica,
Aye.
Dwight.
Aye.
Madam Chair, this motion passes unanimously. Item D6 is a review of the proposed rule changes that are from the PT Compact Commission. This one is always fun because it's not your rulemaking yet. This is the commission's proposed rule changes. This is part of what Erin in her role of delegate will be considering. So right now they are in their public comment period on the proposed rule changes. So the purpose of this agenda item is to give the board a chance to look at what's being proposed. And if there are any concerns, if there are, then we would document that and present it to the Compact Commission on rulemaking. Part of, as you may recall, I believe it was last year, they made a similar proposal and you did have public comment and concerns on some of the ways they were wording this concept of a significant change, and we'll scroll to that in just a moment. So I wanted to make sure in particular to bring these for your review. And Sarah, if you, I think, skip to where things turn red. Yeah, the first change is the introduction of a new definition in the definition sections under T. And where this is coming from is that as a member of the compact, jurisdictions, when an investigation is initiated, we are required under statute to provide confidential notification to the other compact member states that the individual is under investigation. There is clauses in the statute that do allow investigative changes or sharing or combined investigations. And the purpose is to increase the speed of notification to compact members and to link up if there are multiple investigations that might be for the same individual for the same thing. But it is a confidential flag. Some jurisdictions had questions about where they might just have an administrative citation, or they might have something that they don't have CE, or they aren't able to share the information because they don't make a decision about it until after the vote or until a public document is published. And so there was interest in, well, can we make the flag requirement under statute something that's really limited to where there's more urgency than sort of those lesser violations? So they've defined significant investigatory information when the board has reason to believe that there isn't, it's not groundless, and if proven true, would indicate more than a minor infraction. And they also talk a little bit here about the timing, that it's after the inquiry or investigation that includes that information. So it's not just when a complaint comes in, you trigger the flag, but when you've actually looked at it, you have jurisdiction, there seems to be sufficient grounds, you've investigated enough to make that determination, even if it hasn't yet gone to the board. And if in your jurisdiction, it would be considered more than just a minor infraction. Number 2 introduces this idea that if that investigative information indicates that there is an immediate threat to public health and safety, regardless of whether there's been any notice or anything else, that's another trigger for the flag. And then it goes into a little bit about what it doesn't include, that it doesn't include practicing without a license for a certain number of time, or an expired license or privilege for a certain amount of time, or those continuing education violations. So they don't want flags on that. They don't consider, even if you think it's serious in your jurisdiction, they don't consider it significant. That relates to a change down in what the rule is, Rule 6.7, which is on the next page, where they're saying the flag is just indicating the availability of, and they've added the word significant investigative information. So that's how the definition and then the actual rule about flagging tie together. And now I'll pause there. Any concerns or feedback that you want us to share with the commission based on that proposed change and definition of significant information? There is still some ambiguous language in it, but it's definitely better than the language that they had previously. While you're thinking on that, Sarah, if you'll go back to Rule 3.112, bottom of that page. They're also adding this, and frankly, this is based on some impact that's been previously provided by you on that. But this idea about grounds for when the PT Compact Commission can terminate a compact privilege. And it details out when the compact holder has engaged in fraud, deception, misrepresentation, failure to satisfy requirements, failure to provide requested information, failure to comply. And where this is coming from is right now, without this rule, the commission doesn't have the ability to process a termination like this if they discover that somebody has misrepresented their home state, for example, or when they may have moved somewhere. And so those would be referred to the jurisdictions, and then you would need to go through the case contested right hearing before the Compact Commission would act. What this does is for these specific situations, they would have the ability to terminate a compact privilege directly without triggering a complaint in a case in the home jurisdiction. Any concerns with that one? Okay. Then on the next page, there is an amendment that relates to home state designation. This pertains, the language here that's being proposed pertains mostly to active military and spouses, clarifying home of record, permanent change of status, and current residence. So it makes changes there they've gotten questions on cleaning up those definitions. And that's it. Okay. From what I've seen is that the board doesn't have any specific comment to introduce for the Compact Commission's rulemaking. Don't, this isn't the last time you've seen this, because if the Compact Commission passes this rule and adopts the rule in December, then this does need to come back to you because we in Oregon is required to have you adopt the rules of the Compact Commission. They can't do rulemaking for you. And then you would also note in it if you had any significant objections or things that you would exempt from the adoption of the rule. So I don't think I put it down. The one thing that we could do, if you felt comfortable, is about timing. You could allow us to initiate. Right now, what would happen is they would pass things on in December at their meeting, and then it would come back to you to initiate the public rulemaking process to adopt it into Oregon rule. The period that those are out of sync, at least in Oregon, the old version of the rules would apply. So one thing that you could do as a motion is delegate to me initiate the administrative rulemaking process. As soon as the commission adopts their rule, it would still go through the full public process, but that could start, and depending on the timing, potentially then be brought to you for adoption at the January meeting, if that would be acceptable. Yeah, if what you want to do, if you want to allow us to, if you don't have any concerns what's being proposed here, and you're comfortable with us initiating the rulemaking, and it's not on the worksheet, but we would need a motion to delegate the rulemaking authority to initiate the PT compact rules. You could, Joanna, would it be sufficient for them to delegate the rulemaking, to delegate the authority to the executive director, the authority to initiate the administrative rulemaking process related to the PTCC rules? It is a mouthful. Absolutely.
Help me out. I wrote down notes, but okay, I move to delegate to the executive director the authority to initiate the rulemaking process regarding changes to the PTCC rules.
I second the motion.
Roll call vote. Timothy?
Aye.
Aaron?
Aye.
Mariah?
Aye.
Sandra?
Aye.
Hoku?
Aye.
Susan?
Aye.
Erica?
Aye.
Dwight?
Aye.
Madam Chair, motion carries unanimously. Sarah, could we skip to D9, please? One of the things I think it would make sense before the board gets into some of the other updates on strategic plan and updates is to take a brief look at the rulemaking forecast. I know Sarah showed you at the September meeting that essentially all but 2 rules need to be adjusted. Next page. So what this document does is it 2 things. One, it shows with the check marks the rulemaking administrative activity that's already been completed in 2025, and then in August and September, um, um, what was previously identified as possible rule amendments. You did have motions today that would address both the rules and the compact privilege fee. Those would initiate this year, but they would not be completed in this year. That would close out next year. The additional work with the Rule Advisory Committee that was started earlier in the year, that will not happen August through to December. There's not time, and Division 40 needs to be significant. House bill, so it makes sense to line that. So looking ahead in 2026, one of the because of the renewal season, we're not anticipating any significant rulemaking January through April. There just isn't sufficient capacity or time. Other than you should see the items at your January meeting related to the compact and the fee forward. It's entirely possible something else could come up that might come before you, but that we're not calendaring or recommending that we try to do anything more significant, and that we wait until April to begin the work on all the changes out of 3824. So, and that's a body of work that extends into the first half of 2027. One really important note is that even if we began the rulemaking in April of 2026 on an item that's in the bill, it will not have an effective date until July 1, 2027. So it'll be a really long process, but everything will then come online all at the same time in July. Our recommendation in looking at the project is to start with the non-substantive changes in all the divisions. We should be able to go through and go through an administrative rule process if there isn't a significant change. If it's just like a number or a statutory reference, there's a process that we can do without a full rulemaking. And so we get all of those lined up and identified. And then, frankly, because there is so much, working through the impacts to your existing rules, division by division in order. Part of that is addressing the new authorities that are being added in the different sections of the bill. Okay.
I was like, I can't see
Is it a
that, but I
hawk?
just-
Right, right. Well, he'll be part of the recording forever and always. The new authority in sections in the bullet point where it says sections are sections of the bill. Divisions are the sections of your rule, just to keep it nice and confusing. Those are all the elements that deal with section 5 is dry needling, 10, 16, 19. You have your disability placards, you have your sonography, insurance. Those are all those sections. Part of why we can't really start with those sections is they haven't been established in rule yet, or I'm sorry, in statute yet. Though that happens usually in January of even numbered years. So we don't know what the statutory reference is going to be, where they're going to plop it in. And so that's part of why they're, and of course the governor's letter directing the order of the board's focus. Then the deferral of picking back up at that time when we get to Division 40, reconvene that Rule Advisory Committee on the work that had to do with discharge in the context of the new House bill. And then because it happens almost every year, if the Compact Commission has rules again next December, then what we're doing now would have to happen again then. But this is what we're projecting, and this is what we would, if this approach works for you, then this is what we would post on the public rulemaking calendar portion of the website. Okay. Yes.
I know clinicians and employers are very curious about, say, the requirements, say, for dry needling or sonography. Will that information be after we've made a decision before the July 1st date? Will that be posted so that they're able to prepare for that July 1st date?
Yes, and what I anticipate is that somewhere before the end of 2026, we would convene a advisory group and probably hold some interested parties session to get public input even before a rule is drafted, to make sure that everybody has input on what those requirements should be in Oregon, to look at what the requirements are in other states, probably most notably Washington, because it's right here. And so they not only will they can participate in the process to help inform what the rule is. Once that rule advisory work is completed, that would be a draft rule that comes to you. And then that would go out for public comment for the rule itself once we initiate that. And then that would close, but it wouldn't become effective until July 1. Yeah. So I anticipate that we would be starting, if all goes well, that we would get to those new authority sections in maybe the end of third quarter or definitely by fourth quarter calendar of 2026. You bet. Okay. Tends to go back to that's acceptable. I will have one shortly, but way back in the beginning. You're faster than I am. We wanted to pause and take time for folks that were able to attend the recent annual education meeting for FSBPT. If anybody had any comments or thoughts as a result of that, particularly anything that you wanted to hear more about or direct staff to bring back to you for the full board. Open mic.
I'll start. So one of the, I think Sandra was at it too. We went to the one on education and like when boards use education as sort of a action item for disciplinary action, and does that help with, it was more about recidivism and it was more looking at physicians and medical boards. There was a little piece on there, I think it was Texas or something that uses also public service, like community service. But they didn't really have any data on that. And it was odd because I thought it was odd because the community service was sort of had nothing to do with the infraction itself. It was just like, you got to go do some community service. I mean, so that was, yeah, it was like, go pick up garbage because you didn't set boundaries or something. I don't know. But I think the takeaway that I thought was the data supported that sort of targeted education towards the infraction, that there was a statistically significant decrease in recidivism. So that people that were were given education. So, because I think we recommend that a lot as a board, and that I think there's some data to support that. And I didn't know if, I mean, if we had data to support that from our disciplinary actions or something. But I thought that having that resource and that we do try to educate our members a lot, I think is just supported that information. So I felt like that was I don't know, Sandra, if you had a different take from that, but it was really positive. Yeah, like, I mean, I don't know how it compares with fees, like charging people a bunch of money when they, have disciplinary action, but for sure. And I think the time and effort that we put into thinking about the courses that we're recommending, I was trying to look at, because I forgot my notebook, but the sort of the enablers to this remediation were that the needs were identified, the participant has support from their colleagues, the education is well designed. Like those were sort of big factors in that it was a big to make that successful. I think they identified the barriers to sort of that remediation. Let's see if I had that right. It was just some of the constraints, like the resources and things like that. And I think that we definitely consider that when we're looking at educational programs.
Has the board ever used like public service in part of our process?
I think one of the things when we've tossed around that idea or even supervised practice is you kind of come up with, well, how do you monitor that? How do you, it just, much less, the bigger question, does this work? There's that question, does this work to prevent or correct? But also the monitoring part, never gotten past that, I don't think.
Yeah, I don't think, at least not in my tenure, there hasn't been a discussion about it in general terms. I mean, sometimes if there could be a specific stipulated agreement that has a component that could be framed as a community service, but not as like an intentional piece. Where it has come up, and part of it can frame into the non-clinical hours and continuing competence. And also in support of DEI from the standpoint of if a PTA wants to go out and like volunteer or speak with a middle school in order to like help represent and work encourage moving into the educational pathway earlier, is that something that they could receive credit for to encourage that? So the board did have those discussions in 2019, but slightly different focus.
I'm curious, in that class, did they give examples besides, like you mentioned, like picking up garbage, but were there other examples of what kind of community service that states have used?
Yeah, I think
I was there too. I think it was even as simple as volunteering in a thrift shop, like Salvation Army and Goodwill. So it, as Susan said, it wasn't super really related to what maybe had occurred. Yeah.
It is something, if the board's interested, that we could reach out to the state of Texas and ask them either to present or to provide materials on their program, kind of what drove it and kind of what the results are, if that would be of interest.
There was a lot of interest there about it. Like a lot of people were like, whoa, they do that. I don't think many boards are doing that nationally. So it'd be interesting to have them talk. Yeah.
I think I do. I have a copy of the paper if anyone wants to see it.
We can distribute that out and
Yeah.
post it with materials. Any other comments or from the want to highlight or direct us to, bring more presentations about?
I think, oh, sorry.
Go
go
ahead,
ahead.
go ahead, Susan.
I was thinking on the sexual boundaries ones, like some of the, when they were talking about including the case studies and that educational material that was available, and maybe, I don't know, like being able to review that as a board, or like, I mean, that was more targeted towards students and those types of case studies, but highlighting that when we are, and I know that the APTA is doing that as well, but when we're going out to programs, but also maybe just kind of reviewing, since that's new educational material for all of us to be able to review other types of case studies. That you were there, I think, same one.
Yeah, absolutely. We'll note that for additional. I do know that Nancy Kirsch is involved in a current research study looking at PT, Chiro, might include OT, I can't recall, but looking at US and Canadian data. And their preliminary research is showing that if you look at the types of the categories of violations where board takes discipline, they find that roughly 85% of the violations are non-clinical, so boundary, other violations, and that it's really only 15% about clinical skill.
Yeah.
And some implications to that are, about like, particularly for PT schools and how we train, and then for you. So that research should be available soon. Well, that I think relates to that.
I mean, I think that for me as a board member, that was a huge surprise, and like what I imagined, 4 years ago, cases we would be reviewing. So certainly that fits. And I think, for students, having taught in PT and PTA programs, we talk about that. But I also think for current, practitioners who think that that's not what they're going to get complaints about. And I haven't reviewed those case examples, but like open that to members to say like what might, like they might not even consider what that might be, because I don't think they can, everybody thinks they're going to get a complaint against them for that either. So like, oh, this is an example I never even imagined could happen.
I'm kind of debating whether to even bring this up. I've been thinking about it a lot because I feel almost more confused after the presentations that I watched on the values of boards and justifying our existence, which, before I was on this board, I had no idea that that was such a big issue in the country, and then nationally, and then it only gets worse every year, I think. But I felt like the speakers they had kind of raised more questions with me than not. Susan and I also talked about this, but they had and I wasn't like, I don't know, for some reason that whole topic, which they kind of, it was two different keynotes things were kind of on that subject, but I was like having a hard time even like figuring out what the topic was. I mean, it was just hard for me to, I don't know whether it was just where I was at the moment or what, but there were these legislatures that were talking about in their home state, and they were telling kind of pretty horrific stories. And then why they finally come to having a licensing board for that profession. Like one of the examples was, well, two of the examples that were in Colorado. They don't have licensing. They didn't have a licensing board for funeral directors or funeral homes. And oh my gosh. And so they had all these, there was actually more than one that were actually selling body parts and giving kitty litter and sand to family members saying this is your family members remains of multiple, like I want to say it was hundreds of patients, something like that. It was a lot, a big number, and they don't have a licensing board. So there was this legislator that had that in his district was my understanding. And then he worked to get a licensing board. But then they were self-governing, and so instead of like having a public member and making sure you knew you were about public protection, they were supposed to govern each other, which, we also have heard in our board tenures, we've heard stories about how that doesn't work very well to self-govern. And he was still kind of justifying it because that's currently what they were doing. So they finally get a board going, and then they're supposed to like get recommendations from other funeral directors. That's what keeps their licensure going. And they finally do their first aid inspection, and there's a door that's closed, and they make them open it, and there's some bodies in there that they claim to have done something else with after all that. But then this legislature makes a thing at the end like, well, I don't like regulation. So I'm against regulation in general. After you told these stories, I still would vote for less regulation.
Yeah.
That comment, I was just like,
I think that, and the panel that Sandra's referencing, it was talking about the value of regulation. And there was a panel of either 4 or 5 legislators from across the country, and then 4 or 5 individuals that work for regulatory bodies, some like divisions of health, some individual boards. And the in death care regulation, particularly in Colorado, does have some pretty had some issues on that. I think part of his point on that is that death care in Colorado was regulated. And then through a sunset process.
I remember there was a lot of talk
Yeah.
about the sunset, but I really
It was deregulated because it's like, well, what's the risk? What's the issue? And so in their state, what they pretty gruesome, but situations where regulations were preventing things, but he was describing the pendulum, and also the risks of a automatic sunset process. And when you eliminate the statute automatically, this is part of what can happen. And I think his comment at the end was more, there is value in regulation, but it has to be, a lot of folks use the phrase right-sized regulation, that we need to not overburden any industry, that we have to have regulations that actually provide a benefit to the public, and we need to be able to articulate what that is. And if we can't do that on a particular regulation, then maybe it shouldn't exist. And if we can't tell the story of what the value is of the regulation, then we need to, as regulatory bodies, we need to do a better job of that. And that's where it is a very gruesome but very powerful story, for those individuals that were impacted, to be able to share that on why it's so important. And so connecting with your stakeholder groups, your interested parties, your communities, and knowing what their stories are, and bring that forward and connecting those to regulations. But that's also elements of that we could bring to the board with that discussion.
I thought it was interesting. I didn't come away with like, oh, this is what we can do in Oregon, or this is what any individual board can do didn't come away with like, they gave hints like from the other regulatory employees, or kind of how to do it, but I didn't come away with anything that was like super concrete to apply here. But I thought it was interesting thoughts for sure.
I was in it like on a similar note, and maybe it was just the state that I was in, but I felt like I watched a play on that AI presentation, and then I wasn't sure, like, was kind of scary. Like, the woman that was talking about what was happening to all her data. And like like I wasn't sure what the takeaway and part of it, like I know they were presenting it in kind of a fun way in the way, but I was like, I didn't quite have the takeaway from that. Like I don't know. I mean, I think I got more focused on, oh, I let somebody do that at urgent care the other day. And now should I run out and be panicked, like where that data is stored and how long it's going to be stored and where that is. And I guess I didn't have, specific to our state, like what's happening with um, that in terms of are we as a board regulate, how we're regulating that information. I don't know if practices are allowed to just, we don't use that. I mean, we have the EMRs, but what else is happening? So with those conversations.
Yeah, I'll note that as something else. This board has flagged AI regulation as a topic for a future topic. So I think that, I mean, we'll get to that slide in just a moment, but we can make sure that happens sooner rather than later.
I think the other one I went to was the animal one, and I feel like we're pretty, like that was pretty straightforward and easy to apply to like what we're going to be looking at. And because I think that's part of, right, the new House bill is adding some of that language around animal practice, and it seemed like we were on track.
Yeah.
Right. Yeah.
Yeah, I think there's already some language relative to in the exemptions under veterinary, but I think that as you are looking at those sections, coordinating with the Board of Veterinary Medicine will be critical to kind of make sure it's seamlessly going together. My understand is from talking to the director of that board is that these support services, if you will, PT, OT, chiro, massage for pets is a portion of what they're seeing as just exploded in public interest in having those services. And that's part of what's driving some of the legislation that we're seeing around the country. Okay. With that context, can you jump to the next page, please? Under sort of the progress report that is part of all your agendas, doing this a little bit differently, instead of looking back, looking forward, in the context that we've had through the meeting today so far. If we look at strategic planning and the focus just operationally on what 2026 looks like, renewals is essentially all of first quarter. We talked about the significant rulemaking as a result of the House bill all the way through mid-2027. We have some questions marks right now about the licensing system stability and whether or not we need to do a replacement. This is something that strategically you had flagged to begin looking at anyway, because our current contract has under 4 years at this point left. So we would be needing to start the process of looking for either reestablishing a new contract with the existing vendor or going out to RFP or solicitation in some form. ADA Section 508 compliance of websites and materials. This relates to the accessibility of anything that's posted on a government website. It applies to the website itself plus any document that gets posted. We post a significant number of documents. That comes online, I think, initially in April of 2026. So is a significant body of work in of itself. And then, as always, your emphasis on education and outreach in all the contexts many discussed today is a big focus. It goes hand in hand with any kind of rule advisory work that we need to be doing. So it will be another big focus. And when we get to the calendar, we'll talk about that a little bit more. There is a link on this slide that it links to the full strategic plan, but those are the highlights of what we're forecasting for 2026 operationally, which doesn't leave a lot of capacity, frankly. Next slide. This is hard to see on purpose. This is your roundtable and future agenda items. What I just didn't want to quite lose yet. This is the last meeting of the year, but this is your topics that you've already identified and covered within the year. And then the next slide looks at what your standing docket is, if you will, for future topics that have been identified already. And I think the discussion that you just had about the annual meeting, and we've added a couple of other things that will add to this. And what we also want to start doing in 2026 is bring this information to you. I think some of it would work well at, because some of this is like reports or studies. So like the first item, PT, PTA student debt trends. This is probably something that we can acquire a report to share with you in your packet as opposed to a live agenda item, at least at first. So we'll go through and calendar. I would anticipate that all of this and even the things that you've identified, either through packet materials or outside speakers, we can address these topics for you in 2026. Any other, in addition to what we highlighted through the last discussion, not that I'm asking for more to be on the 2026 plate, but are you comfortable with what's here, or is there a burning topic that you think is more critical that you want the information on? The topics related to House Bill 3824, you're going to get a broad gambit from animal welfare to sonography to, I mean. Okay. Then if, Sarah, if we can skip to 7. Only a placeholder slide, but you're so good. All of that context, I know we are running a little short of time today. So what I wanted to do was bring at least a high level, a little bit of discussion for the board. We are taking all of the prior work that you've done this year and compiling that into an update of the written document. We don't have that ready for you today. Part of it is we looking at the operational list for 2026, and that House bill, whether it had passed or not, made a huge difference on our workload for 2026. But as a reminder for strategic planning, you have had 4 pillars, 4 sort of strategic objectives or areas of focus: trauma-informed regulation, culturally responsive regulation, prevention, and then optimized operations administration. I think that if everyone is still comfortable with those as your primary sort of lenses on the strategic plan, that everything that I've heard you say seems to fall into those areas on that. And because of the kind of work that we have for 2026, I think that there's also a very intentional focus on community engagement that falls under those pillars. The rulemaking process, the focus on training and outreach, and then further diving into data analysis and reporting based on some of the things you've asked about today, and engaging the community in those processes is something else that needs to be a focus. That brings us back to, you'll see the calendar in a moment, but one of the discussions that came up, I think in May, was the idea of moving board meetings around the state. And when we talked about it as staff after the fact, what we wondered is there interest in licensees attending your meeting physically, or is there something else that could be of greater value to them in communities around the state? And would it make sense for us to look at, instead of hosting a board meeting in another part of the state, hosting like a continuing education opportunity in the state that could be done adjacent to some of the outreach that we do when Sherry, for example, is elsewhere in the state with a school or other activity that might take her to an area, that we could host an event or a training in those communities, invite everyone, and then at least the board members that are in those communities come and attend and outreach as well. So when we were talking about that, we thought that that might generate more interest, be of higher value to licensees, to rotate those kinds of events around instead of the board meeting itself. And in part because folks can attend remotely to all board meetings, no matter where they are. That was one question that I have for the board.
What was that state that did that big,
Louisiana.
yeah,
This would be sort of like a little mini-me version of that.
Louisiana?
Yeah, to kind of test the waters in the different communities. And it's even something that we could, if we know that we're going to be in a particular area, we could do community outreach. What would be of interest to you? If we did this kind of topics? And the idea would be, again, free, right? A free lecture, free continuing education that you would get credit for, to kind of encourage that. And it could be on topics that the board wants licensees to be more aware of, sort of a win-win.
I have been invited to go back to Louisiana to present again this year.
So refresh everybody's memory what that event is.
So the way they did it, I don't know how they're doing it exactly this year, but the way they did it last year, it was free. It was put on by the board and the professional organization. They have some required CE hours. Not 100% sure what they are, but it met, the whole weekend met all the CE requirements that people need. Whatever their period is. So the day that I presented was all topics like boundaries and sort of ethics and things like that. And then the first day was a lot of presentations on reimbursement, and they had people from different insurance companies and attorneys talking about, like, what if you get sued, things like that. So that was the first day, very reimbursement heavy, because I guess a lot of people have questions about that. And then the second day was all ethics and boundaries. I'm not exactly sure if they're doing it the same way this year.
It was hugely successful. They
They
didn't know how
had,
many people would come, and it was,
I think there's 350 people
Yeah.
there. They hold it in Lafayette, which is kind of in the middle of the state. So people can come from all over the place, drive for the day, or it's in a hotel, so people spend the night. A lot of people spent the night. I'm not sure exactly the cost to them to put it on.
And that is
I
one
think it was pretty
factor.
high
They,
because they brought in a lot of speakers from all over the country
yeah,
to speak.
and they have like a dedicated fund, a fee source that generates the fund that allows them to do it in the way that they do it. But I think that it demonstrated that there was a lot of value to it, and it's something, Sherry was one of the presenters last time, will present again. There's no reason that she can't give that same material to Oregon licensees in a
Right.
smaller format.
I think it's kind of, it's revolutionary because it's putting the board in, it's bringing the board into people's lives, their licensure into their people's lives, rather than just a rubber stamp or something. It's really it's more integrating the value of your license and being more proactive. I liked it for that, because, and that it was so well received. I think that. there's
And
a
I
lot
think
to say
that
about
the
that.
rather than the board, I mean, like, because I tell when I'm taking time off, like, oh, I'm going, come on, sign on. People don't really care to come on to the board meeting. But I think understanding where, like, especially with, renewal this year and where that money, what is your board doing with
Yeah.
that money? I think would be more something to go around the state to do, like Southern Oregon, like some education on I mean, obviously with the new House bill for 2027, that's a big piece that people want to know about. But I think some of the rule changes that we did around, progress reporting and sort of it looked like PTA supervision kind of stuff, like some of that education. And Sherry, some of the topics that you've talked about, but also what to do when your phone lights up and it's Sherry Prue calling you from the board and not asking you about chocolate cake, but asking you about something's happened, like how to respond to that. I think
Then it's
people,
really me, not a spam
yeah,
scam.
right. But I think presenting on the HRI stuff, like educational like resources that the board has for licensees. I think just doing a broad educational program to take around the state like that would be more well received than, oh, we're going to be doing this day-long board meeting. Not that I don't love them, but yeah.
I mean, I think a good start is I reached out to the APTA Oregon to ask if I could present at their annual meeting that's coming up. They put out a call for presenters, and I was like, hey, why don't, I do this all over the country. Well, I should do it for us in this state. I'm still waiting to hear if I got accepted in. I hope I do. And then there's definitely other times of the year where I have to be in other parts of the state anyway, like I have to be in Bend twice in 26. So I figured I could do it then in Central Oregon and then figure out like when we present to other schools, like Gayla and I just went out to Western Oregon, which is, down near Salem kind of area, Salem, Eugene, probably be pretty easy for people to get near there. So we can kind of mix those things in.
And there's more, Southern Oregon has Medford area, some conference spaces. I know in the spring, the ESD is opening up their new building, which has a bunch of conference space available as well. Yeah.
I'm feeling like the attendance would be small if it was in person, unless it's in conjunction with another event. I wonder if a virtual platform would be better.
I
You're
think
going to get a different crowd. I think, in a sense,
Offer both, I guess.
I mean, OPTA has the doc talks, those hour-and-a-half webinars. I mean, that seems like a great opportunity for getting a different group of people outside of the students, and probably employers and directors, that are likely to attend that more, is my thought.
Tim, you're absolutely right that I think that even with in-person offerings that we need to do more virtually and increase that. I think and it is part of why I think surveying the communities, and asking them, what do you want? And what would be of value and when? Because sometimes that ability to interact with face to face, right, and meet a board member, meet the staff, and know who they are, not just in a Brady Bunch box, but in person. I think there's also value to that, particularly if we're already in that part of the state. So, it's like a minimal thing. But you're absolutely right. I think the bigger bang for the buck is probably those virtual offerings. The other piece, the compliance, particularly on technology, needs to continue to be and we just talked about AI and everything else. Regulatory systems are beginning to implement AI into that. So it's not just AI regulations of the profession, but what is the appropriate use of AI by the regulatory body. One example is that for continuing competence certificates, some of the systems are beginning to implement AI to look for the pieces of whether it's a qualifying certificate. And if not, during the process is, hey, you need to upload a better picture, or I'm not seeing this element on the certificate. Can you make sure it's there? As a service. So that's something that we may, at least over the next couple of years, if and when we look at a new system, that's some of what we might need to look into. And then The other piece that I'll mention that's important for 2026 is there will be potentially, there are several board member terms that are ending. Some of them are, one of them is second term. So we will have to say goodbye to Erica at the end of 2026. But there are also, and at the very end of 2026 with Sandra. So that's 2 of 8 positions that would be changing over in the calendar year. And then there are several of you that are coming to the end of your first term. And so personally thinking about, will you put in an application to apply for a second term? And if you're not going to be doing that, to let us know. But there's the potential for a lot of change for the board itself that I think needs to be part of our focus and planning. But that's kind of a teaser and kind of our thinking and the framing of what we all want to pull together. My personal goal is to translate that all into a written document for you to look at in January. So I put that on the record so I can hold myself accountable. But as long as that directionally all sounds good, that's what the next step would be for you to review.
Can I say one more thing about the AI thing? Because it came up, sorry, but it was about like that, the way they presented that was like the patient's information. But like if that's happening, and sometimes when we're looking at an investigation, it's like, well, this is what the PT said, this is what I said, this, like, if those conversations are stored somewhere, like, can we ask, like, we could get those conversations, right? I mean, if that's part of that question that I had. If people are using that, like, could we just in terms of, I mean, that's for that investigation, but I just wanted to get it out there because that was another thought I had, like, not just what the patient's saying is being stored, but what I'm saying as a provider is getting stored in my tone, if it's actual transcripts or the recordings, like, is that investigatory information? But
yeah,
that's
it
all.
potentially could be.
Yeah. Okay.
Yeah.
And then how do we know if our term is expiring?
It is posted on the website, but we can also follow up with everyone and make sure you're aware of that. Okay, we have one more general session item, if it's okay to go just a little bit. Okay.
Michelle, is it the schedule for the board meetings?
Yes.
Can we hold it till after lunch?
Like put it into the second?
Yeah,
Okay.
we've got, the person to my right has a lot of conflicts.
Okay. Then yes, it sounds like we should, Madam Chair, let me double check. Yes, the election of board officers. If we skip to number 10. And this was an added agenda item on that because Gayla verified that we had switched our term from the fiscal year to the calendar year, and we extended the currently serving through December 31st. So we need in this meeting to elect a chair and vice chair for the 2026 calendar year. Now that we aren't doing the delegate and alternate delegate positions or the compact delegate positions, we can talk about those in the January or March meeting because of the timing. But we do need to make sure that we have elected officers. So as I understand it, Madam Chair, because of your term ending, you do not want to run for president for 2026 or for chair. You're retiring.
Yeah.
So the position of board chair is open. And our vice chair is, well, let's hold on vice chair. Yeah. Is anyone interested in serving as chair for 2026?
Vice Chair, are you interested in serving? Oh,
Well, Madam Chair, would you like us to hold the discussion item? Okay, then we will pause that. Then I would suggest convening into executive session. Sarah's ahead of me.
The time is 11:56 a.m. and the board will enter into executive session pursuant to ORS 192.6602 F, H, and
Big L.
L. Oh man, I need glasses. Executive sessions are closed to the public. Any attendees will be asked to wait in the waiting room or placed in the virtual waiting room during the executive session and brought back into the meeting room prior to the board reconvening into public session.
$1,500 civil penalty, suspended for 6 months with a board-approved ethics class or classes. Upon successful completion of the class or classes, the amount for the classes will be deducted from the amount of civil penalty, with the balance of $1,500 civil penalty due and payable to the board at the end of 6 months.
I second the motion.
We'll make sure you write it too that way too. Roll call vote. Timothy,
Aye.
Aaron,
Aye.
Mariah,
Aye.
Sandra,
Aye.
Hoku,
Aye.
Susan,
Aye.
Erica,
Aye.
Dwight.
Aye.
Madam Chair, the motion passes unanimously.
In case PT 926-10/25, I move to close the case.
I second the motion.
Roll call vote. Timothy,
Aye.
Aaron,
Aye.
Mariah,
Aye.
Sandra,
Aye.
Hoku,
Aye.
Susan,
Aye.
Erica,
Aye.
Dwight.
Aye.
Madam Chair, the motion carries unanimously.
In case number PT 927-10/25, I move to close case.
I second the motion.
Roll call vote. Timothy,
Aye.
Aaron,
Aye.
Mariah,
Aye.
Sandra,
Aye.
Hoku,
Aye.
Susan,
Aye.
Erica,
Aye.
Dwight.
Aye.
Madam Chair, the motion carries unanimously.
Case number PT 908-05/25, I move to not reopen the case.
I second the motion.
Roll call vote. Timothy,
Aye.
Aaron,
Aye.
Mariah,
Aye.
Sandra,
Aye.
Hoku,
Aye.
Susan,
Aye.
Erica,
Aye.
Dwight.
Aye.
Madam Chair, the motion carries unanimously.
Number PT 925-10/25, I move to offer a stipulated agreement with the probationary license with the restrictions that the licensee may only practice physical therapy under another licensed physical therapist in eyesight or earshot until September 2nd, 2026.
I second the motion.
Roll call vote. Timothy,
Aye.
Aaron,
Aye.
Mariah,
Aye.
Sandra, Hoku,
Aye.
Susan,
Aye.
Erica,
Aye.
Dwight.
Aye.
Madam Chair, the motion carries unanimously.
Number PT 78. Okay. Okay. That one, in case PT 924-10/25 and PT 931-11/25. I move to issue an interim cease practice stipulated agreement.
I second the motion.
Roll call vote, Timothy,
Aye.
Aaron,
Aye.
Mariah,
Aye.
Sandra,
Aye.
Hoku,
Aye.
Susan,
Aye.
Erica,
Aye.
Dwight.
Aye.
Madam Chair, the motion carries unanimously. Any other motions as a result of executive session?
So
Okay. So then we have a few items from the prior public session earlier today that we need to return to. The first one is item 8, which is the 2026 board meeting calendar. And my apologies, Sarah, I don't have that page number. Yep, you got it. And what we did, the version that was published in the packet, after publication, we became aware of a couple of conflicts. So we have amended the original with some new dates for your consideration that are listed on the page. Amending the January meeting virtually to the 14th and 15th, but the same times on those. March being amended to an in-person meeting on 3/13. The May meeting being shifted to a virtual meeting on the 27th and 29th in the pattern of the Wednesday evening and the Friday morning. July is as written. Scrolls a little further. The September would be moved to the 25th. And November, the recommendation is the in-person board meeting, which will give you 3 in-person meetings for year. So that is the proposed 2026 board meeting calendar as amended for your consideration.
I move to adopt the 2026 board meeting calendar as amended.
I second the motion.
Apologies. Roll call vote, Timothy,
Aye.
Aaron,
Aye.
Mariah,
Aye.
Sandra,
Aye.
Hoku,
Aye.
Susan,
Aye.
Erica,
Aye.
Dwight.
Aye.
Madam Chair, the motion carries unanimously. And the last item on the agenda that we have is D10, the election of board officers. I did start the introduction on this item, the first part, but as a reminder, the terms for the chair and the vice chair are coming to an end 12/31, the end of this calendar year. The board this year shifted from a fiscal year to a calendar year format for the officers. And as a reminder from earlier, we are not voting on the delegate positions at this time. That'll come before you either January or March when we know when the meetings will be and what the obligations will be for the delegate positions. So with that, starting from who is interested in serving, starting with the chair position. Else? Have one candidate for the chair position. For vice chair, currently Hoku. Hoku or anyone else wish to run for vice chair for 2026? Anyone else? We have Aaron. Not seeing any other volunteers. Then, Madam Chair, what we could do is one motion to elect the slate of candidates, which would be Susan as board chair and Aaron as vice chair for the 2026 calendar year.
I move to elect as board chair Susan Reynolds, and as board chair and as vice chair Aaron Crawford for the 2026 calendar year.
I second the motion.
Roll call vote. Timothy,
Aye.
Aaron,
Aye.
Mariah,
Aye.
Sandra,
Aye.
Koku,
Aye.
Susan,
Aye.
Erika,
Aye.
White.
Aye.
Madam Chair, the motion passes unanimously. Congratulations to the candidates. And I do also want to take, I don't know if there's such a thing as an administrator's privilege, but I would like to take that for just a moment and just thank you, Erica, for your years of service as board chair. It's been a delight, and you've done a lot in. So thank you. I know it's your last meeting today as chair.
As chair, yeah.
As chair.
Till September. Nice, a couple more times.
And with that, I don't believe that we have any other business to bring to you today. So with that, Madam Chair, at your discretion.
Okay, guys, the time is 3:11 p.m. and the Oregon Board of Physical Therapy is adjourned.